Welcome to all of you who have joined this morning. It's a pleasure to see you. We do want to value and enjoy this meeting, and we're very glad that you've been able to be with us. Today's meeting will, as usual, be recorded and published on the Health Board's website after the meeting for viewing. I'd like to welcome Dr. Michael Allen instead of Tracy Deskovich, so welcome. And apologies for absence are Tracy Deskovich, the Director of Public Health, and Richard Clark, one of our independent members. Anybody else accepted to welcome them? No? Okay. Are there any declarations of interest that we need to note before we start today? No? Thank you. Could we start with the consent agenda business? This is our first experiment with the consent agenda. The independent members discussed the running on Monday, and in respect of today's consent agenda, I've received prior notifications that the following items will be brought forward from the consent agenda to the main agenda for discussion, and those are 724, the Strategic Risk Register, and 723, the Public Service Ombudsman for Wales annual letter. Does any member wish to bring any other of the consent agenda items forward for further discussion, or are we content with it as it now stands? Agree? Okay, thank you. Update from me then, 3-1. Oh, I don't know, it's been incredibly busy. Apart from my usual visits, which I really welcomed, and we must ensure that the independent members' visits are also reinstated on a regular basis, please. And my meetings, I've had 2 accountability meetings with the Cabinet Secretary, 2 Cabinet Secretaries. One was on my own, and the Cabinet Secretary now holds chairs to account for the performance of their health bodies on a quarterly basis, and that was one of them, and that was held with Mark Drakeford. These are fairly forthright meetings, and you are likely, no doubt, of what is expected by the end of them. But the dialogue about the productivity improvements and the general workflow through the organisation is useful to share with the Cabinet Secretary so that he gets a deeper impression of what the pressures and concerns of the Health Board are. And one with my fellow Health Board chairs on sustainable services, change, and the importance of the dialogue that we're all having with the public and patients. There have also been 2 Regional Partnership Board meetings, one of which was yesterday, where we have discussed issues relating to carers, the regional investment funds and how they're being used and their evaluation. And we have agreed that an important part of evaluation has got to be the added social value of these schemes and proposals to the communities that we're seeking to serve. We've talked about system resilience. The first priority of the new Cabinet Secretary is system resilience during winter. Fortunately, when last winter decided to implement a number of additional schemes, and they decided to implement them for 2 years, not just 1, to ensure that there was some continuity and those schemes could grow. And that, I think, is serving us well. We still have a number of system resilience issues, which are all acknowledged, and everybody's working extremely hard, the Health Board and local authorities, the carers and the third sector, to overcome some of the difficulties that we are all experiencing and our population is experiencing as well. We talked about integrated care developments. And we've also talked about children's services. We had a report yesterday from the Children's Partnership. They're taking forward a number of proposals in the planning stages about the needs of the population in terms of children, the main concerns arising from children integrated services, and the way in which actually the service for some children, particularly those with CAMS issues, have improved. But that was welcome, but we are still pushing to improve things further. I've also had a meeting with the Welsh Audit Office about the structured assessment. The Chair's peer group has met twice, and we have discussed at length targets, staff development, morale and leadership, because that's really important, and we hold that in very high regard, that we really do need to continue to support staff in an effective way. We've also discussed the future vision for primary care, which is really important at the moment, and we will have a joint meeting of Health Board chairs and the vice chairs about the future vision for primary care in a couple of months before Christmas. And we're bringing experts from all around the country to be able to advise us on the schemes that have been developed elsewhere, how they've worked, because we need to improve primary care services and accessibility to them. We've obviously talked about digital and the whole issue of prevention, and also the operating of the new executive, its focus and purpose, as it bends out in its second year. We also have a special meeting to discuss asking for a meeting with the new secretary and the sorts of things that we felt were important, which included prevention, an assessment of productivity and cost effectiveness of care, the rationalisation of services, pre-hospital care, capital, because we need capital investments in order to modernise, including digital, social care and its greater alignment between health and social care to maximise effectiveness, and mental health services, together with the necessity for a 10-year vision for the services. And we await his response, but then he's only been in about 5 days, 10 days. I've also met the chairs of Clwntaf and Cardiff and the Vale about the initiative that is being pursued by the three organisations to rationalise our services and to improve them together. That's proving to be very successful, and we do have a meeting between the chairs and the chief executives about that issue next week. I've obviously met the leaders of local government, and we've been very fortunate that we've had in the last 3 weeks really 2 visits from 2 cabinet secretaries. One to Neville Hall, where Mark Drakeford, who was then the cabinet secretary, was interested obviously in Iraq and the issues that we were facing there, and very, very interested in the intermediate care award run between ourselves and Monmouthshire County Council. And last week, Jeremy Miles, the new cabinet secretary, came to visit the new breast unit in YYF. And that I think was a very helpful visit for both for him and for us. It was very interesting that there was, a real sense of enthusiasm and influence and how the services were developing and how they had improved the outcomes for people and the timeliness of care. So that I think was quite a very useful meeting at YYF. And I'm grateful, very grateful to the staff on those occasions for answering the questions so well and providing confidence to the cabinet secretaries. Are there any questions? Thank you.
Yeah, thanks, Chair. So, coming on from the busy period you've been in, it's unbelievably honest, the first half with the start of the year really, and the summer is over, so real focus on delivery. There's a lot of information in the board papers today around Q1, but there's absolutely focus on delivery, and particularly around our emergency care system, which continues to be a significant threat ahead of the winter. So I think the resilience plan for the winter is going to be key. And the planned care priorities are on the waiting lists. We are making progress. We've got more to do. cancer and mental health continue to be key priorities for us and set by the Cabinet Secretary and the First Minister. So our delivery against our plan is absolutely fundamental, including our financial plan, and that's being reinforced regularly with Welsh Government about delivering what we said we would deliver as a minimum. In parallel, we're preparing for the new planning round going into next financial year, whilst we're also progressing well with our strategy refresh, which again we're hoping to be completing at the end of the next session. I know we've had some sessions as a board briefing sessions on the progress being made on that. As the Chair's mentioned, it's been a busy period working at both a regional and national level. The regional work being covered, as the Chair mentioned, particularly around ophthalmology, diagnostics and cancer, but with a number of other areas such as stroke, where we're continuing to look at how we can better work together and strengthen our services in the region. There's a lot of work going on at a national level, and the Chief Executive's also been having discussions about our primary care model for Wales. There's been a lot of workshops taking place over the early part of the summer that is now coming together to really make us think about what that model of care looks like for the future. So I'll anticipate we'll have more discussions on that at the latter part of this year. And there's a lot of work at international level on value and sustainability and performance, where the Chief Executive of NHS Wales working with all the Chief Executives, make sure we come together and we are sharing this, and we are working at a national level where that benefits us. So they are proving to be very beneficial and making sure that we are sighted on where other health boards have possibly made greater progress, so we can learn from each other. There's been quite a bit of work around the new Joint Commissioning Committee as well, in terms of the new format for WISC and ESC and the National Collaborative, just to look at how we can work more effectively on that particular agenda. So it's been very much in that kind of forming development stage, but I do feel that it's going in the right direction and be beneficial for us going forward. And I think just out to the chief, myself and the executives continue to be out and about across the organisation. Really important that we are visible and listening to the people across the organisation. We had a useful session yesterday, a number of us with the new consultant induction. It's always a good opportunity to test the moves of the new consultants into the organisation. And again, digital being a key theme for those who are really keen to be engaged in our digital agenda. And I'm really pleased the EPMA is on the agenda today as just one of a range of schemes we know we're going to improve on that agenda. And I've also been doing some informal sessions with staff who had Patient Choice Awards. This is the 400 patients and family that put forward members of staff through the awards process that we've been doing informal sessions to recognise them, and some really beautiful stories and feedback from families and patients that is really valued by the staff. And I know Jen and I are looking at ways in which we can capture more systematically the positive feedback that we are getting. And I definitely feel in the last few months the number of compliments that are coming to me directly and feeding back in terms of some of the great care it has been quite exceptional. So we are looking at how we systemize that. And Civica is our patient experience system. Again, we've agreed that we're going to get the SMS text in for ED as a priority. So that's really good. And then I had a lovely visit recently to the arts and therapies, and I know we're going to come on to the patient story, but again, I was really pleased to be welcomed by Joy and the team to share some. So thank you, Chair.
Thank you. Are there any questions to Nicola? It's a very, very busy time because you've got the increased scrutiny from Welsh Government and the executive on top of everything. So I'm glad it's still all able to get out and about to see the services and the staff. It's really important. Thank you. Could we move on then to 4.1, patient experience? And I'm pleased to welcome Joy Rickford, the head of arts therapy, today to present a patient experience story.
Thank you very much for having me today on behalf of Arts Therapies. It's lovely to share a patient story with you. A brief introduction to Arts Therapies, because not everybody might be familiar. Dan, if we can slide over to the beginning, is that okay? There we are. We're psychological therapists at MA level and HCPC registered, and one of the 13 or more allied health professions in the health board. We've used theoretical bases in our work, just like any other psychological intervention. But in addition, we use a creative therapy, be it music, drama, or art, to engage with somebody and their processing of their thoughts and feelings to have a therapeutic intervention. We tend to work with people for whom talking therapies might not be the best fit, and often people who are in chronic or very difficult, vulnerable situations. We've been in the Health Board since 1982. You can really own that. And there are 16 qualified art therapists across the Health Board. We're all part-time, so the whole time equivalent is 7.54 even. And 10 of whom are in art therapies titles, and the remainder are in other titles working in a psychological way, just because there aren't very many roles. Okay. A very brief scan. I know it's a little bit small, but there is some inequity in terms of access to art therapies across the Health Board. So in learning disabilities and older adults, there are small part-time teams. In adult mental health, consistently, there's been one art therapist for over 40 years, so it's done really well. And then more recently, there's been one practitioner in CAMS. It's something that we're really looking at. There are also other people, as I mentioned, who are qualified but working in other roles. So in ABSTAS, in the alcohol dependency, alcohol specialist drug and alcohol service, and also in adult psychiatry. So I'm also in an unusual role in that it's Health Education Improvement Wales Pathfinder role, and it's short term. So we've got some funding. There's never been a professional lead for our profession yet. So we're taking every opportunity we can. All right, we can move on, Dan, thank you. We extend our reach with student placements, and there are 9 this year, and often generously supported by non-art therapists in areas that there are no art therapies available. So with psychologists, and sometimes that's been long-standing. That's something we've done a quality improvement project on to support and give better governance and better links. We can move on. Thanks, Dan. Okay, just to bring you to the heart of this story, I'm going to share a 2-minute video about what it's like to attend art therapies in learning disabilities. This outward-facing video is to help patients, staff and carers. And it's me some of the time. hopefully that's given you an insight into the rooms that our patient story comes from. So Aaron has been so kind and shared his story. So this is a reflection from an audio image recording, which is an outcome measure tool, and it's also a therapeutic tool at the end of therapy. So in therapy, somebody, when they get to the end of those sets of sessions, they'll look back, they'll look at the art that they've made and the meaning it had for them, and be able to review, hopefully, in whatever way they can, how that's been and what they want to take forward from that experience. So Aaron in this is talking to Jess Gordon, who's his art psychotherapist, about his art therapy journey with her. Thank you. If you have any questions, I know it's a bit unusual, but what I reflect on when I see that story is the use of metaphor and how nuanced the interactions can be when you use creative arts alongside a psychological therapy and as part of it as a co-therapist in a sense. It means that some of the unsayable, disgusting and unpleasant parts of our human experience can be safely discussed and shared and experienced safely with somebody and in the presence of someone who won't reject you or judge you. And actually, it means that sometimes when we're working with people for whom a range of therapies and medication may be on offer, it can be also a route to stabilise and secure their patient experience so that they can work it out themselves and then be more receptive to the general treatment. So in terms of added value, that's another role that we might have and have had for a long time in different circumstances, sometimes with a lighter touch it can be. Those are my next steps. That's kind of a to-do list of what's happening for us, just trying to shore things up post-March and see what we can do. Welcome any questions or we can move on. I know I've taken a lot of your time, so thank you.
Thank you very much. Story. That was a really, really great story. I think we're all really pleased to see the huge improvement that's been able to make. Yeah, that's excellent. Thank you. Are there any questions? Paddy?
Yeah, Peter.
Peter?
So, thank you, Chair. Thank you, Joy. Just to say, not really a question, just to say thank you, really. Arts therapies are one of those allied health professions that not many people know about in the organisation and been doing great work for many years. And Joy and her team are a really active part of our AHP community within the Health Board, and Joy participates in that. So they're not an isolated profession. She works really hard to integrate in the rest of the Health Board. So just a huge thanks, Joy, to not only for sharing the story, but for everything you do to support arts therapy in the Health Board. It's really appreciated. Thank you.
It's because we've been enabled and given space that that's possible. Being other or different or unusual, as it were, is part of our bread and butter. But if people can actually make good use and through understanding, we can be such good sort of co-productive allies in the work that we offer and the patient experience that we give.
Nick?
Yes, well, thanks, Joy, and it's a lovely story, and I think it is one of those professions that lots of people don't know about, and in part of our workforce and going into schools, you wouldn't think if you was in the creative arts there was a job for you in the NHS. So I think it is one of those that's really worth kind of promoting and has got some huge benefits. And then the other thing I know we talked about was how you capture the outcomes and the evaluation of the work in terms of the difference, say, Aaron's story has in terms of his need for support from our services and how he then goes to live more independently with a different level of support. And I know one of it is about, I suppose, because it's not as well known, how that kind of keys together as the difference art therapy can make for some people that traditional therapy doesn't make for. So again, how you get the support to evaluate the work you do in a more, I suppose, a measurable way that can help demonstrate what the art of the possible is for this type of work. So I know that's something we picked up to try to follow on.
We're joining in with an allied health professions, the Wales-wide outcome measure on the value and impact of allied health professions. So it's a broad brush, but it will be sort of local to here in terms of our looking at our findings. But I think there's got to be lots of different qualitative and quantitative data sort of pulled together so that we can get a truer picture in this day and age, as it were. And also, I think, in addition, if we can look at a few vignettes from different parts of the Health Board as to what the cost savings might be for somebody who is better integrated.
Sarah?
Thank you. Hi, Joy. I'm Sarah, and I'm Director of Workforce and OD, and I have so many questions for you in terms of how we might be able to link together, that very meaningful patient experience there. But what could that mean for our staff experience and supporting the work of occupational health and our wellbeing service? So I would love to link in with you following today's board meeting and have that discussion if that would be something we'd be happy to do.
Totally, that's really part of our remit. We do offer staff support within the teams.
Thank you.
I just wanted to know where you and your team are based.
So learning disabilities is based, the clinical area is in County Hospital, and then there's offices in Thetford Grange. And then we're just Gwen wide, actually. That's what we should expect to be in our car, basically. Thanks.
I am James Calverton, the medical director. So that was a real eye-opener because Aaron clearly had difficulty expressing himself verbally, but that was a pretty deep, rich story, wasn't it? And reflecting on some of the patients that I see who on the face of it, may not seem to have communication difficulties, but I know from my own work with them in clinic that there's quite a lot of stuff in there that they can't get out verbally, and I refer them on to traditional talking therapies. How much crosstalk do you have with the traditional psychologists within the health board? Can they refer into you, and do they?
Yes, they do. We're often very aligned with psychology, and some of my colleagues are working alongside and sort of almost working from the same sort of referral pathway. Definitely. So in learning disabilities, art therapies and psychology are next to each other in psychological therapies. So that's a sort of entity in itself. We do co-therapy work as well. So for instance, there's somebody with forensic mental health issues and learning disabilities that a psychologist has been working with. But at the moment, it's really very difficult for him to just focus on a dialogue. And so we're going to co-work for a period of time with that psychologist to support him with a drama therapist, because he often moves around the room a lot and uses ways of acting out and perhaps separating out his thoughts with different metaphors, in a sense, to make it easier. So that happens. I'm sorry, I'm just very excited, so I have to but yes, it does happen a lot. There's so much more rich information and rich internal dialogue going on that won't be visible. And I think that can come through.
You don't just work with learning disability patients, you work with them.
Mental health, so people in acute mental health wards. Paul Mauer had a student art therapist on placement there, and there was a man, I don't think I'm breaking any confidences, but who was very, very withdrawn and finding it very difficult to accept any kind of treatment or to receive medication that would have been appropriate potentially for him. And he was working with a music therapy student, and he started singing more, and he just really felt himself kind of into his own skin. He started to take up space, started to greet people in corridor, while he was passing them by, and was a lot more receptive to other therapies because he'd had that kind of positive experience of just being. There is also a partnership and alliance with Arts in Health. So while they don't have a psychological training, actually a lot of the arts engagement does have some kind of therapeutic value and social engagement, that kind of thing. So there's a lot of partnership working, and there has to be, because we want to expand and support the offer to patients. So while we're trying to be as clear as we can about what each of us individually offer, there's just trying to create those links more and more. Louise?
Oh, thank you, Chair. And thank you for the presentation. It was very interesting. Thank you. I just wondered, a few years back, your referral criteria was only at crisis point only. Is that still the criteria for referring into you?
Louise, which area are you thinking of? Because it is true, that's one of the criteria. Is it for learning disabilities only, or is it for adult mental health? Sorry, I don't know where to look, Louise. Apologies.
That's okay. It's okay. Well, I just wondered why learning disabilities. Well, all of it really. Just wondered if the criteria had actually changed.
So there is a sort of a list of criteria. Sometimes it's due to I'm looking not at the screen. Sorry, Louise, but I should be able to see better. So looking at whether somebody's acutely withdrawn, whether their behaviour has changed and it doesn't look to be a physical health issue, to do with loss and transition. It could be all kinds of things. Often it is when they're at risk. However, there are models for access, say, around primary care. If you look at the work of older adults, in that they can actually receive referrals from the memory care pathway in primary care all the way up to inpatient care and work on the wards. So older adults is a model in its own about how they receive referrals. And we're just learning. I started in this role in January, so I've been running to catch up. But I think criteria for referral is really something we'd want to look at. But because it's such a finite service, it's just trying to find the sweet spot of where we belong, where we're the most added value. But no, we don't really ever want to turn anyone away. And that's the thing, because anybody, pretty much anybody could benefit. But it's just working out in this context how we're going to make use of it. But yeah, always worth an advice and consultation conversation with us if somebody's concerned, because that's the other thing we do. Even if we can't offer intervention, we might offer advice and consultation and have some useful and resourceful conversations that could lead to better care. Yeah.
Okay, thank you very much.
Thank you. It's a great question.
Jenny? Mine was very brief, and this is just a fantastic story. And for me, it's how we lift up the stories of our unheard groups into our listening and learning framework, and how we start to bring that rounded approach to patient experience across the totality of our population. So this is a really great example of that, and the impact on a profession which is small in the scheme of things in terms of lifting up those stories is so important. So I wanted to thank Joy for coming.
Are there any further questions?
Thank you, Chair. Yeah, just to note that last month I attended the Wellbeing Market in T Sirion. That's the first time I'd seen the arts therapy service there, and it really was a wonderful thing to see. So, yeah, just thank you for everything you do.
Good. Very much, John. Thank you very much, everyone. I'm so glad that people have access to learning new ones. Sorting yourself out. Yeah. Thanks very much, everyone. Thank you. That's what I do. Could we move on to talk to and the report from Sides and Lisa?
Good morning, everyone. Hope you're all well and safe and dry now. I just wanted to touch on the arts before I go into the report, really, because we've been working with the strategic art team in the health board, and we've been part of the Grange exhibition and the Tredegar Wellbeing Centre exhibition. And I have to say, the feedback we've had from patients, their families, visitors and staff in terms of removing barriers to just generating conversation has been hugely powerful. So I just wanted to share that with you, really, in terms of removing barriers to engagement. Art is absolutely very, very powerful. So I just wanted to put that into the mix. Really heartwarming. Thank you for that. So in terms of our update for Slice over the last 8 weeks since we last met, it's kind of echoed in Nicola's update around the work and the push locally, regionally and nationally as an organisation. I think there is huge appetite to have real difficult conversations around the challenge, but also looking at opportunities of connectivity around some real key areas, such as the cancer transformation programme, for example. And I think that's quite refreshing in terms of where we are and that appetite to really engage in change, but really listen to the voice of citizens. And, you know, I really do feel that it's genuine appetite to listen to real people who live in our areas, to shape services and to really listen to say, you know, this is our experience and where things haven't gone quite right, and this is how we could change things moving forward. And I think that's really reassuring around our position of where we all are at the moment. What I would say, what I will share with you today is there are no surprises, but there are still significant challenges across health and social care services and people's experience. But then there are also, you know, imbalanced successes around people's experience. So just to give you a flavour around advocacy, so our complaints advocacy service is peaking in demand. Key themes over the last couple of weeks have been really around NHS appointments, so GP and hospital. And again, I know that will be no surprise to you, but that does continue to be part of a key theme for us, and around experience during hospital admission. And I'm hoping that that will unpick as part of our ED programme moving forward. And I think a lot of people's experiences around navigation of the system. What happens when things go wrong? Where do I go? Who do I speak to? How do I connect the dots? And a lot of our work is around making sure people are supported to connect the dots, and they have an outcome, they have a resolution in terms of what happened during their experience within health or social care services. So again, no surprises, but it really is still bubbling quite lively across our communities. There's been a huge increase around representations and service change. Many of you are part of those, and I won't go through all of them. They are included in the report. And again, it's around local and regional representations. There is an increased appetite to work across the South East Wales corridor, and how we connect health, social care and wider partners together to ensure enhanced quality of care and patient and citizen experience. I guess just to move things forward, we are looking at, and I know again there is quite a lot of conversation around this, how we ensure equity and equality of the voice of children and young people around health and social care. And for us at Slice, we are really committed to ensure we connect with organisations locally, regionally and nationally to avoid duplication, but to strengthen understanding and voice of young people in access of care. So for us locally, we will be obviously feeding the Children and Young People Strategic Partnership that goes live next week, that Jane Rogers is chairing. But we are also going to be teaming it with lots of our community-based organisations to ensure we really get under the skin of the voice of children and young people. Last quarter, we engaged with just over 138 young people at 2 sessions, and it's really powerful in terms of their voice and experience around care in health and care in social care services, and how we can really understand where we can make changes to improve their quality of experience. And when I shared at the RPB yesterday was just a flavour from a young person, neurodiverse young person. And again, this is increasing in terms of an area being supported through the service, GP service, and they're really struggling to find the high use of phone call appointments impacts their already heightened feelings of anxiety, and they find it really difficult to open up and build relationships of trust due to lack of face-to-face appointments. And I think, you know, for us to be interested in how we can work collectively to be able to progress some of these challenges that our young people are facing. And also, it was quite interesting. So dentistry, again, as you are aware, is it's a topical subject at the moment. And a young person shared with us, you know, I haven't seen a dentist since I was 16 and I'm 24 now. I haven't seen one since because I can't register with an NHS dentist and I can't afford to pay private. So again, we are linking up locally around understanding that, and we are part of the Dental National Strategic Board in terms of exploring how we can support the voice of individuals to guide direction of travel moving forward around dentistry. So in terms of engagement, it's been very, very busy period of time. We've obviously been supporting the health 10-year strategy engagement, and are really, really super looking forward to seeing the conclusion of that and supporting live implementation. We've also been busy really looking at community services and the difference they make. So we had a visit to Able Day Centre in Cwmbran a few weeks ago, and I have to say the feedback from every single person who was supported through that team, credit to them, has been 100% positive. There were no negatives shared, and the service is invaluable in terms of improving their quality of life and life chances. We've also been busy with GP exit surveys, particularly at Ringland Health Centre. We're part of the way through our multiple visits to support understanding where the community and patients are around the new 19 Hills Wellbeing Centre. And we have a live GP survey online locally and nationally that we are supported to be completed face-to-face or online. Once that piece of work is completed, we will obviously share with you the intelligence that falls out of that. We've also been building relationships with care homes, and care homes actually is building in terms of people making contact with us, both as part of their healthcare and their living care and support care. And I mentioned in multiple forums this week, housing really does seem to be becoming part of the intense picture in terms of when we're having health and social care conversations. And it really would, you know, I guess for us, it's about how we look at prevention and linking the health, housing and social care agenda together. Key areas that were flagged in particular, Monmouthshire are quite vocal at the moment in support around care homes, and obviously there is the potential care home closure in North Torfaen that we've been actively involved with to make sure that there is voice around the residents and wider families. In terms of emerging themes, we have flagged, I think we discussed early emerging theme last time we had time together on maternity services. We've shared key information with Jenny Winsley's team, and they are providing reassurance and an action plan around where we are with maternity services. We will be doing a project to do a deep dive around maternity services to ensure we maximise our learning and the voice of individuals, looking at November this year. And we'll be working very closely with Jenny's team to be able to pull that together to ensure we maximise the learning around that particular project. We then move on to hospital discharge. So we are looking to release our survey December this year, and that will run through to March next year. And this will be very much based around discharge from hospital back into community care. So we will be working with health and social care partners, and there is a bubbling of a pilot to commence within the Blaenau Gwent area, and I will update you more at our next session together. Just in terms of up and coming activities, so we are now live with our transition from child to adult survey across health and social care, and I'm very keen to run this until the end of December this year, in line with our mental health work that we are keen to push forward. And we're connecting quite heavily with the whole person, whole system and strategic board to ensure connectivity and to ensure the voices that we're capturing are being fed into the right strategic boards to be able to influence levels of change. Our key project that many of you would have received an email from me earlier this week will be our emergency department project. So you will remember last year we went live with a winter experience. This year we're pulling it forward slightly, and it's going to be an all Wales programme of works. So we go live the 30th of September until the 27th of October, and our team members will be active within the Grange as our emergency department, but also they will be present within the acute medical units and minor injury units following the request of Anne, to ensure we get that whole picture around emergency care and support. Once we complete that intense piece of work, we will accumulate the data and the voices that are captured and share that with you probably at the end of this year. And then just lastly, we've got a series of topics that we have that will be delivered by health and social care teams coming up in the next quarter. Again, particular focus on mental health, supporting crisis and prevention, and how we move health pathways forward in the community. So it's quite busy at the moment. We are trying to support and plan. Obviously, winter is nearly upon us now, but it's been a very proactive, lively, quarter. So thank you for your support to date. Any questions?
Thank you, Lisa. That was very helpful indeed. Are there any questions to Lisa, Jenny, and then
More of a comment, Lisa. So I've investigated the maternity concern you raised, and I'll have a response for you early next week. We have a maternity services improvement plan, so obviously we'll pick up any learning as part of that improvement plan. We have got a really engaged group of mums who work with us through the Babby group. So when looking at maternity experience, it'd be great to connect you into the chair of that group who's a layperson. And also, we have our new Children and Young People's Strategic Board, which the board will hear more about next time internally to the Health Board. And again, getting that user voice through will be really important in terms of the connection of your understanding of the themes that are coming through. But we are going to refresh our work on transition in particular. So it'd be good to connect in with you about that piece of work too.
Brilliant, thank you.
Thank you, and thank you very much for the report. It's very comprehensive. It obviously outlines all of the activity that's been going on, and it's good for us to understand actually, what work you have been doing. Obviously, you're a fairly new organisation, and the way in which the reports are presented to us is different from the way we've received them in the past. And I think for me, one of the things that would be really helpful is to understand, for example, when you say things like, it's no surprise that one of the things that's top of people's list is GP appointments. I think as a board, it would be really useful for us to understand, is that a problem because people can't make appointments through the app? Is it a problem because people are stuck in a phone queue? What's the kind of themes around why people are having issues with GP appointments? Just for an example, and you've given several examples. And I think if we could have that kind of thing in the report moving forward, it would be really helpful. Thanks.
Thank you. Any further questions to Lisa?
Yeah, thanks, Lisa. It's Nicola. I just wanted to just have a follow up with you separately around some of the dental access, the issues that are being picked up, just so that we can kind of give you a briefing around what people's, where some of the options are. So even if the local dentist has got a long waiting list of others, other options. So maybe we link you in with Lloyd in the primary care team so that you've got the information at hand as people come to you, which hopefully will make things easier for you. Thank you.
Thank you.
Anything further? No, thank you very much, Lisa, for all that you and the team at Lice are taking. Could you move to 5.1? The service development business cases, starting with urgent and emergency care still.
Thank you, Chair. As the board will be very well aware, emergency care is a key priority for us for a number of reasons, patient experience, safety and risk. And very disappointingly for the board, we were placed into enhanced monitoring in January 24 for urgent emergency care pathways at the Grange. I think it's fair to say the teams have been working tirelessly to improve the situation, and we were prior to, I think, that's been placed in enhanced monitoring. And the paper outlines, I think, some of the progress that we've made sort of to date in relation to that. There's a weekly meeting that I chair, driving forward a series of improvements that will help us deliver on the three measures outlined in the paper. 1 hour ambulance handovers, the wait to be seen, and 12-hour waits in emergency department as well. So very clear expectation from Welsh Government and importantly our patients about sort of the improvements that we need to see. Subsequent to that as well, we've had several periods of industrial action. So we've had opportunities in terms of learning around, in particular, senior decision making and review. And I think that you can see from the paper that we have seen improvements, but that doesn't take us far enough in relation to the improvements that we need to see. So the paper outlines a request for board to consider 2 schemes for investment that I believe and the teams believe will make a material difference to both patient experience, the safety of our system, as well as sort of organisational sort of reputation. Those 2 areas for investment is the Grange Transfer Lounge and investment in emergency department consultants to support the senior decision making at the front door. If I take them just very briefly, because the paper outlines, I think, sort of the request, and there's detailed business cases attached to that. But for the Grange Transfer Lounge, for those of you that won't be as familiar from an operational sort of service delivery perspective, we do have a small transfer lounge. Originally, the Grange didn't have that factored into the designs, but it only holds 6 space in big enough for 6 beds and 4 chairs at any one time. The modelling shows, because of how it's currently being used at the moment, we only see about an average of 5 patients a day through that, a mix of discharges and step downs, because you'll be aware of our step down model. It's a small space, but it's not big enough in scale, and partly driven by some visits that we've done elsewhere. Jen led a visit to Musgrove Park. When prior to us opening the Grange, we went to Southmead as well. They have a much bigger discharge, they call it discharge lounge, but ours would be a joint discharge and transfer lounge. So the proposal sets out a modular build at the back of the Grange Hospital, co-located with our current transfer lounge, that gives us capacity for up to 12 beds and 20 chairs, starting off with 10 beds and 15 chairs. So the 50 discharges a day and the 13 step downs a day would have a facility to manage patients through that process. We've done a lot of detailed work. We know by and large, outside of the peaks and troughs, that admissions and discharges are pretty balanced. It's the timing of when those patients present and hit us through the day that cause us significant pressures in the system and cause delays for our patients sort of in getting to the right place in the system. So the request on the discharge lounge, a transfer lounge, I'll come on to the consultant case at the moment, would be to proceed with a revenue lease option for that modular build at the back of the hospital to enable that discharge transfer lounge to proceed. We already have staff. It's currently staffed on an ad hoc agency, bank and agency basis, normally 24 hours a day, but we use it as a ward. The proposal is to shift it to a 12-hour model so that we use an example. I think from last week, we had 8 patients ready to step down that we could have just instantly moved in the morning had that been available. Had a significant impact in the system. The investment for the transfer lounge for this year is 189k with a full year revenue potential for 659k, and I'll come on to some options that we might have to pursue that at the end of my debrief. So, as I said, request to proceed with the revenue. We will pursue, there is the potential for us to pursue some capital funding for that, but we have no guarantee that will significantly reduce the revenue requirements to about 250k on a full year basis. But as I've said, we will pursue that separately. But in order for us to proceed for winter in particular, even though it's delayed, the board is requested to support the option to proceed with the revenue so that we can try and get something in place for winter. On the emergency department consultant position, we have done a lot of demand and capacity modelling on the workforce required to keep a pace with the demand coming through the front door. And as I've said already, the evidence that we've seen from the industrial action period shows the material impact it has when we have senior decision makers at the front door. At one point, we were in industrial action, but we had a completely empty sort of waiting room, which was a very significant difference to some of the pressures that we're experiencing at the moment. The investment of 6 consultants in total will deliver a senior, rapid clinical decision-making function on an 8 to 8 basis at the front door, as well as increase the sustainability and robustness of weekend cover, as well as support sort of our children's emergency assessment unit on a twilight basis. So 3 areas of particular investment that will support improved patient experience, safety, and, as I said, sort of the view that we will de-escalate from the enhanced monitoring that we find ourselves in on urgent and emergency care. The investment requested for the consultants is 57k for this year and 780k on a full year basis. We are confident we will secure the staff. We have tested that with the team. We're currently out to advert anyway from a replacement and are hopeful that we would be able to have those staff in place in readiness for sort of next April. In terms of the investment, because of our financial situation, we're very, very mindful of that. But in the scheme of reputational damage, but most importantly, patient experience and safety, the investment that requested is less than 1% of our overall turnover. So, and has been accounted for in the innovation reserve that has been set aside and is set out in the paper. The paper sets out the worst case scenario in terms of revenue impact. I know Nicola has already had some conversations with Welsh Government colleagues around potential sort of access of funding to offset that. And as I've said, we will pursue capital opportunities in particular and the lease of the modular build to try and mitigate or offset the revenue costs. So the board are asked to support the case for investment for both the Grange transfer lounge as well as the ED consultants, set in the context of the pressures that we've got on our urgent emergency care system.
Thank you, Leanne. That was very clear. Questions? Joy?
Let me see, we've had discussions around the input into the department
Sure.
for over a long time, haven't we? And we've commented before on a number of people coming into the department that aren't necessarily urgent and emergency cases. Do we have a view on how many that is currently still? Because I know we've tried to divert people away to the right locations for them. Do we know what volume is still coming through the department?
Pilots that we've done recently, Ewan, is we've had a GP at the front door alongside our triage team. So we've also implemented e-triage as well to give us some consistency. So we've got a new system in place that gives some more consistency around that. But the GPs that we've had piloting or sat alongside the triage teams are very experienced, I think, and capable GPs that have determined actually that the work that the triage team are doing is appropriate and actually that there's very little gain for us there in terms of the diversion away from the system. So it is...
Do we know how many people are turning up at the wrong place?
they say that we are appropriately triaging patients to the right place, and the redirections that we are undertaking for ourselves are appropriate.
So what's the volume that you will be giving us any?
Sorry,
context?
the percentage is relatively small. It's less than 10%.
The GPs were identifying a maximum of 3 people a day who they felt could have been dealt with elsewhere. So an absolute drop in the ocean. And I've been in the same conversations that you have, but what has changed is the public and our flow centre are directing far more people to the minor injuries unit. So over the last couple of years, there's been a doubling in the number of people who've seen in the MIUs and the ELGHs. So it feels as though we've got the kind of patient mix in the right place. One thing that was very impactful for me is that GIRFT has come and had an exterior look. And, if I were to summarise, I think they can't work out how we're managing as well as we are, because we lack so much processing capacity for our patient volume compared with comparable centres in the UK. So we're about 30% understaffed for activity levels per consultant in the department.
Yeah, because one of the concerns we had is that people were presenting there because they couldn't get a GP, back to the GP appointments and all the rest of it. So if we're now down to what we think is our emergency, is there a risk if we open up and have greater capacity for volume that we'll start seeing people coming in then because they can't get a GP appointment, or instead of going to a minor injuries unit, because there's none of that modelling in there of, if we've got this increased capacity, times come down, actually, instead of going, just go to the Grange, instead of going to Heath, I'll go to the Grange. If we get better, is there an increase in capacity that because we've increased the capacity, we can handle a greater volume?
So I think that clearly that is a risk. We can't sort of legislate for patient behaviour, but I think, again, what we must ensure is that the work that we've done on our triage processes remains robust and solid, and we monitor that so that doesn't become the case.
Which is going to be my next one. Are those controls going to be there and robust enough to handle that additional volume that comes in? So that we're not just, there's more volume, we can just pack people in.
So there's a weekly update in relation to sort of the numbers that come through as part of the enhanced monitoring. We continue to track the redirection percentage. So we will have, I think, a very timely update or a risk of that not happening. I think we will flag that very quickly. And I think the feedback that we would get from the team as well, because they're working incredibly hard in very difficult circumstances. I'm sure many of you sort of know the environment they're working in. They don't want people at our specialist RE emergency department if they don't need to be. And I think the final check for us that we've done with the GPs alongside, because the GPs will, as I said, particularly, we've made a request that they were experienced GPs to really test that we are doing everything we can to divert patients to the right place. So I'm confident we will have systems in place to pick up should that happen, albeit I don't believe that will happen.
The GPs were particularly keen to feedback how good they thought the triage was. They worked side by side with the triage nurses for a number of days. And I think we were all really pleased with how good the feedback was. These were fresh eyes and people with no investment, if you like. They were there to provide us with their advice. So I think we've got the structures in place that provide the right processes within the department to try and alleviate the concerns you've had, which are the concerns that we've discussed as well as a group.
Paul?
I think the reality is that the original idea was a critical care centre for the Grange, and over time I think the introduction of the GP triage has made a real difference, and I think that's incredibly helpful to get the evidence that it's not about what used to be called self-presenters that were causing the problem, but that the message has got clear about what the services are in our communities that can be accessed and how they can be accessed. I think the slightly remodelling of the service, which is what I think Leanne has put forward, I think is hugely, hugely important. I think the report is incredibly helpful. I think it's thorough. I think it's thoughtful. And I think we should watch this space by monitoring and reviewing it over time. I think the the sort of the help that Nick has given to try and bring in some additional funding, I think again is helpful. So my view is, this is something that needs to be done as quickly as possible and get it actioned as soon as possible as well to get the staff in, and let's make a difference in terms of reducing the sort of the numbers that are waiting. So it gets my full support.
Thank you, Pippa.
Thank you. And I kind of feel that this is it's very good to see a sort of whole system approach, because obviously if we can manage to move people out of the wards into the discharge lounge, then that's going to create some space for people at the front door to be making quick decisions, to be able to get people into the wards. And my hope for our patients is that if we're able to make quicker decisions, then our patients will be less ill when they get into the wards and hopefully get discharged quicker anyway. So I think, the combination of these things together, I think, is a really good approach. I just want to make sure that we evaluate it very quickly to make sure that it's having the effect that we want, so that we don't leave it too long before we evaluate it. But absolutely supported as an approach to streamlining things, because that's just going to be better for people at the end of the day.
Sorry, Anne, do you mind if I just come back on the point that Pippa has made, because I think it's really important from an assurance perspective from board. So we're obviously in enhanced monitoring. So as a minimum, we have monthly interventions and meetings with Welsh Government on this. They've been, the roadmap we've got for improvement includes these developments. There is a very clear expectation of delivery in relation to this. They're supportive of the approach. And we have tried not to do more of the same. I think we've tried to build in an element of getting the system working in a different way going forward. So the evaluation will absolutely be ongoing. There'll be a lot of scrutiny about this. I've been very clear with the teams about the expectation of delivery, and I think just as a potential way out, should it not pan out, 6 of our consultants in ED are over 50. So in terms of the turnover piece, should the investment not do what is expected, but I've been very clear of around, should we secure this investment and what the expectations of delivery is.
Ellen?
I think very pleased to see obviously the impact of the GERF visit and actually quantitating our staffing levels compared with what is expected as a standard, with some very hard and fast evidence. Also that they were saying that the comorbidities of our patients are probably much greater than in many other places, perhaps particularly in England. And so we're actually dealing with more complex cases that are coming through this. And you've already made the efforts to transfer things, the simpler things, back to MIUs and that sort of thing. So also good that you've been visiting other places about the discharge lounges. I mean, obviously finance is a big issue. If you had to prioritise those two, between putting the staffing in first to increase the speed and throughput versus the discharge lounge, do you know which one would make more difference? Which should be more beneficial if you had to take one at a time or do it in stages? So it's difficult to do try to do two things at once. And
they're very discreet, so I don't think there's any operational difficulty in delivering both. I don't fundamentally believe the discharge lounge won't make a big system perspective. The ED consultant is departmental based, and I don't think you can get around the senior decision making expectation at the front door. I don't think. If I were really asked to commit, I'd say discharge lounge first from a system perspective. But I don't think that we will not deliver on the expectation of enhanced monitoring on the wait to be seen in particular without that investment for ED.
I see them as being inextricably linked. I think if you invest in the front door without the back door, all you'll do is force people through quicker into a congested system. If you go for the transfer lounge without the front door processing capacity, you won't make full use of it. So they are both part of whole system solutions in the pressure points we've identified.
also, I think if you know that there are potential staff available to fill those posts, then speed is probably of the essence before somebody else picks them up.
Penny and then Hannah.
Yeah, somewhat naive question. Really welcome the 6 extra consultants in light of, of the reports coming through. Just wondered why it took an enhanced for Welsh Government to implement enhanced monitoring for us to recognise that we needed 6 extra consultants, because surely that was. I mean, 6 is a large number, and they're going to make a tremendous difference, and it's fantastic. But surely there must have been some hint of it beforehand. Is it just the fact that it's, funding that we were thinking of before or whatever?
No, the team have been working on a revised demand and capacity model from a staffing perspective. Obviously, we opened the Grange 4 years ago now. There's an element of the system settling for a little while. And I think probably about 18 months, 2 years in, the team started working on a revised demand and capacity model with our ABCI team and the mathematical modelers. So that took probably 12 months, to be honest with you, because of the level of detail, and you can see some of the graphs. There's an enormous amount of work that's gone into this. And obviously, from a board and organisational perspective, we're trying all the time to mitigate needing to spend additional monies in terms of trying alternative ways of working. So they have been working on it prior to the enhanced monitoring, just for assurance. This is not just because what government have waded in, and we're cited on where our risk sits. The original modelling suggested, just for context, about £5 million worth of investment. And there was a lot of scrutiny on that and significant pushback from us around it, and hence the revision of the case to just 6 consultants, which I know is a lot in the grand scheme of things from an investment perspective, but it's taken, I think, that time to have done the work to ensure that we've got something robust and is required and needed before we brought the case to board.
Just after that, yeah, it's just to reinforce. I think it's a fair challenge, but I think picking up Ewan's point as well, we needed to be content that all the work we did and then to the right persons going to the Grange, where we can make efficiency and pathway changes without an investment was key while we were doing the work around that demand and capacity as it's settled. And I think in our financial context, making sure that we've got as much of a robust kind of evidence base to support. And I think the recent GIRF visit helps reinforce the case. The visit to around the transfer lounge was important, so that evidence base, because any investment decision we make in this current time is critical. So I think it's just to reinforce, this is a piece of work we've been on for years, and I think we now got greater clarity about what we've been able to resolve, and this is where we think we need to make those priorities. Thank you, Penny.
Yeah, just briefly, just first on that point, in our annual plan, we committed to developing and bringing forward these proposals from the earlier versions through to the final version. So sort of as then the other bit I just want to give assurance on so from discharge transfer lounge perspective, there is on the lease the revenue on the option a relatively small capital requirement that is deliverable within our discretionary plan. So just to give the quantum we still have left in that plan due to slippage this year. So that can support that. Jan touched on it. There may be an opportunity, or there is an opportunity to be invited by Welsh Government to submit any additional bids against end of year capital. So there is an opportunity to pursue that. But as Leanne touched on, there's no guarantee, and there will be a few opportunities we'll be seeking to explore through those end of year capitals. So we'll continue to work with the team to see how we can mitigate any.
Well, that will certainly make a considerable difference to the revenue costs on an annual basis. Neil?
Yeah, I'd just like to say, I think there was a comment in papers about how this is described as running as a very hot part of the system. I can certainly see that, and really, I'd just like to add, my impression from the papers is that if we have a system that is running hot, and this is perhaps the hottest part of the whole system, it seems to me that we really should support this, because not only are we solving the problem in that, or hopefully solving the problem in that specific area, but that there would be considerable, possibly as yet unrealised benefits
throughout the whole of the rest of the system. And you know, given the sums of monies involved, I thought, and we have to make choices. It does seem to me that the amount of money involved, this is likely to give us the biggest benefit of the many other options that we have.
Can I just build on that? Because it struck me that if you have more rapid turnover, what then does the model, what the consequences for the rest of the system look like? And how can you move around your resources to make most effective use of the resources that we have? And what does the model start to look like if you've got rapid turnover and all these senior decision makers, although they only seem to be there for half of the day? I don't know if that has consequences, but then what is the rest of the model?
So two comments just back. So the senior decision maker is on an 8 basis. The view of the teams, because we have quite a lengthy debate back and forth in terms of 24 hours of a need. If you look at the demand and capacity, and we deal with the work when it presents, that backlog should not be there, the overnight sort of cover, and the staffing that we've got overnight, in fact, is the only area where we have surplus capacity potentially. I think there's so I think that deals with and there's been a conversation with the team that should that not deliver to the standards that we expect, we will be reviewing the time of operating. So I think just for reassurance, because I know we've had a conversation about it. There's a wider, I've only touched on some of the work that's going on across the urgent emergency care system. One of the key interface areas that we're working through at the moment is emergency department and acute medical unit, because they are inextricably linked. And we saw when we were running the SRATs pilot, even outside of IA, sort of an increased number of patients in a congested AMU is clearly not right. But hence the reason why the discharge lounge, James's point about how linking the front door and the back door is so important. Jen is doing a whole host of work on the Under 6 goals, which you'll be very well cited on. I think some of the integrated front door offer work that's being done will help route patients to a more appropriate setting. That's the holy grail. It's getting the patients to the right part of the system as quickly as they possibly can, and matching the demand and capacity and the workforce that we've got to do that, so patients get the best outcome and experience, because at the moment that's currently not how we're set up to deliver. So ongoing work with the emergency department and acute medical unit. I know that the board have asked for an update in October on the ELGH reconfiguration, so we can go into that in a lot more detail in October. But just to provide board with assurance, we look at this on a system level continually because of unintended consequences and how patients flow through the system. So we do have work that cover that up that I think would mitigate sort of any risk that causes.
Good. I think the board needs to remain excited on this. As this is a key area of concern for us to improve. Thank you for that. Are there any more questions or comments? If not, are you content to approve the additional investment set out in the summary? And we will review it 6 months after implementation as a first stage to make sure that the model's achieving what we're starting to achieve what we have. Thank you. Thank you very much for that. The MRI scanner, you're going to be busy, aren't you? The MRI scanner for the brain.
I'm always busy, Anne. Okay, thank you. The board will be aware that when the Grange was originally built, there were facilities or room available for 2 MRI scanners. At the time, we took a decision just to put 1 MRI scanner on in the Grange and left the room sort of there. It is, I think, sort of a considerable concern for us, because it is a single point of failure for us just having 1 MRI scanner in part of the system that is so hot, using Gerf's commentary sort of for us, because effectively that means that if we have a failure of the MRI in the Grange, then patients have to be transported for MRI from the Grange at the moment. So it is a risk for us from a patient safety perspective. The board will also be aware of significant pressures on diagnostic waiting times too. And the organisation, we have been using a mobile scanner to keep the waits down for MRI on one of our other sites at the moment and incurring revenue sort of off the back of that. So the Grange is now sort of 4 years old. The scanner is 4 years old and will be very shortly due for probably replacement as well, which I think is also driving sort of concern. So the paper sets out a request to approve the case being submitted to Welsh Government for the capital case. There is a view, I'm sure Hannah will want to comment more, there is a view that Welsh Government will look upon this favourably for a number of reasons. We believe it's deliverable in year out of sort of capital slippage. We believe it will resolve a very significant, I think, sort of potential patient safety risk for us, as well as giving us a tick in the box as part of our regional diagnostic plan. Just, I think, for assurance of the board, the revenue that we have committed in the clinical support service division plan is neutral. There's no deterioration from a sort of a financial perspective because we are already and have already spent that money on a mobile scanner. So it does give us the potential for expansion at a later point in time should more capacity be required. But at the moment, the case caps it at the revenue that we've got committed in the plan to 6,000 scans. So the board are asked to approve onward submission of the capital case up to a value of £2.5 million to Welsh Government, that I know Welsh Government are waiting for the case on, so that we can resolve this patient, this risk for us, as well as support further improvement on the diagnostic and planned care agenda.
Yeah. Thank you for the paper. Are there any questions on this? Let's have it.
Yeah. I noticed from the business case that we have a growing, in addition to the risk caused by having one scanner and the mobile scanner in place, we have a growing deficit in terms of capacity for MRI scans. I think that starts out at about 1,000 or so, grows up to nearly 14,000 by 2028. Even with the addition of a new scanner, but as in between 6,000 and 8,000 scans, that still leaves us with a substantial deficit over the next couple of years. Does that mean that we're likely to need to come back next year or year after and for additional MRI capacity to handle that growing deficit?
I think that you will have seen lots of cases around growing diagnostics. In particular, I think it's a personal view that I think the way in which training is completed now means that there's a very heavy reliance on diagnostics as part of the clinical pathway, much greater than I think sort of historically we have seen. There is a very significant growth. I'm sure probably worthwhile doing something maybe at a board development session on diagnostic growth and sort of potential sort of for the future. But I would anticipate that at some point we will be coming back with a request for further scanning investment. That needs to be set in the context of the regional case, though. There's lots happening in the regional case. My point around, I guess, sort of we've been trying to work on regional diagnostic hubs, and each of the teams and the local health boards have identified what their solutions would be in terms of the community diagnostic hubs, and this forms part of our solution, I guess. So it's accepted within the regional sort of environment that this is a good solution for us and we can sort of progress. But I think that it's definitely worthwhile us thinking about maybe a diagnostic session with the board.
Yeah, I think the just bit, I absolutely agree with this. This case stacks up. We should definitely prove it. I think the area of concern for me is it's obviously already operating at a very hot level. There is no spare capacity in our current setup, and the addition of one new scanner, that capacity is almost entirely eaten up immediately. and that leads us in a situation where if there is a failure of an MRI scanner at the Grange or one of the other sites, we then have a substantial deficit as well on top of things. So it feels like this almost isn't enough. We always try to meet current demand, and we don't ever seem to go beyond that, and that then means we end up in really difficult situations where we have to suddenly find emergency solutions to solve issues. It's a bit nervous that we might end up in a situation again.
I think it'd be wise to have a diagnostic session so that we can see what the demand's coming in, because we've got the backlog, which this one, if these two are working side by side, it's always more effective to be able to manage that. But I think to have a session on that, and also the regional operations, I think would be important.
You're absolutely right, David, very insightful. This is basically a case to stand still because we're already using the mobile scanner. This conversion from the revenue into capital case for us gives some sustainability and reliability in the system. It does give us a small area of growth because it's only at the moment suggested that it operates on a Monday to Friday basis. The rest of our scanners operate 12 hours a day, 7 days a week. I had a message from my auntie at 20 to 8 one morning. I was waiting for MRI on one of the sites. And that's not the case across the region. I think we do absolutely our assets. But I think just for assurance from a board perspective, we're at 99% at 8 weeks from a MRI perspective. So I think we are delivering the expectation of the targets of us at the moment, but we are very mindful of future growth. So would really welcome that session to update the board on the work that we've done and how well I think that we've done to maintain the position that we have.
Anna, and then Neil.
Yeah, I think so, Chair. I think one of the points I was going to make have been more in terms of the iteration of a regional perspective, as Jan's touched on. So across the whole of the region, there's infrastructure resources that aren't yet all running at full capacity in terms of days and hours. So there is we don't sit in isolation in looking at the future growth. And there's also aspirations and some health boards to increase that capacity further. So for that next step change, it's important when we have that session to look at that. Yeah. And the other point I was just going to make is, again, a bit similar to one. This has been in our pipeline of capital program projects high from a priority perspective because of the risk issues in terms of single point of failure. So it is, as Jan touched on, is expected. And they're waiting for it in Welsh Government and this opportunity with the invitation for end of year spend. By the time it's coming to us today, we can submit it and they've approved next week.
Okay, thank you. Neil,
I welcome a board briefing on this situation with diagnostics, and just building on David's case. I don't think this is necessarily just a hypothetical question, but it makes, building on David's comment, it makes me wonder, for example, if we were to have 2 additional ones rather than 1, what would that do in terms of potentially, making ourselves future ready, but also helping? I'm not advocating for this, I'm just asking whether we could explore that conceptually to give us a sense of what the freeing up of the system that might deliver for us. And maybe that's something we could look at in the briefing.
I'm disappointed that wasn't a real offer, Neil. I'm disappointed that wasn't a real offer of a second scanner.
You've still got capacity.
We have. I am teasing. There are quite a lot of considerations, I think, in terms of the placement. Part of the reason the Grange is so important is because of that risk of a single point of failure as well as the capacity. We've got some opportunities, I think, around place-based care. Where would we put another scanner now? Because I think the infrastructure, the build of or the installation of scanners is quite complex, actually. Much more complex than the chief operating officer could give you detail on. So I think we need to consider it carefully.
No, I appreciate it. It's very complicated. for it. I just think that as a group.
Yes, good health. Over. Alan?
Thank you. I just wonder, obviously, you have an extra scanner. Have we got the staff to run the scanner and the radiologist to report the scans that are produced?
Yes, in simple terms, we've been very successful in terms of radiologists because of the increase in the number of trainees through the academy in particular. They've got crazy numbers of trainees coming through now, actually, through the academy route. So we're confident that we have been able to recruit the radiologist in particular and the radiographer support required for that.
Yeah, and I'm just an aside. Of course, we'd have to go down the route of planning, wouldn't we, as well, if we were going to have more than one, I think, wouldn't you? Yeah, and that would add time to a lot of time, probably. I'm just going to ask, are the diagnostics about to be replaced or require replacement soon? Because, I do know of a case where one aspect wasn't working and one part wasn't working and they used the MRI scanner instead, which is quite drastic, really. But I think it was a temporary blip. But what I'm asking is, are all the other diagnostics up to scratch, or are we going to have an influx of replacements?
We have a regular replacement programme on diagnostics, CT scanners, plain film rooms, screening machines. It's a very technical area. It eats up quite a lot of the capital programme, both at an all Wales level, but also from a discretionary. So we always have a regular placement programme of replacement for our diagnostic equipment. I think full board assurance, we always make an assessment in terms of, is the technology changing? So there's been, is there a change in modality, for example, around the type of tests or pathways that are coming in to determine that? But I think for assurance, for the board, it is quite complex. It is very rigorously monitored and managed because obviously there are radiation sort of regulations around it as well. And so that is managed appropriately by the division and very well by the division, actually. We do very well at an all Wales level. Our general manager in CSS is very well tapped into the national position because it often serves us well in terms of replacement should there be slippage or year-end monies that come out that allow us to do that then, because they have faith and belief that we will deliver when they give us that capital. So we do work really hard with those with Welsh Government colleagues on that, but it is very well managed.
There's nothing further. Are you happy to approve the onward submission of this turnkey capital business case to Welsh Government? And that we will stay within the revenue reform. We move then to number C, electronic prescribing and medicines administration system, P4.
Thank you, Chair. Board members will be aware that the Minister released a statement in 2021 which set out the direction to digitise electronic prescribing across all care settings in Wales. As a result of this, 4 programmes were set up to deliver this ambition. So firstly, there was digital prescription between primary care and community pharmacies. It's called the Electronic Prescription Service. Secondly, there was a programme to support patient access. So this will help patients understand which medicines to take and when, and also record in their pharmacy of choice, as well as the ability for the patients to record over-the-counter medications. All this will be delivered via the NHS Wales app. Thirdly, there is going to be a shared medicines record. This will enable medicines information to be shared across organisational boundaries in Wales, but also in the future with NHS England. And finally, there's the Electronic Prescription and Medicines Management Programme, known as EPMA, for patients admitted into hospital, which is what this business case relates to. So as the paper sets out, EPMA can improve patient safety, quality of care and medicines management processes across the organisation. And it's acknowledged that this is a significant transformational programme and the pre-implementation phase has been funded by Welsh Government. and has enabled the Health Board to complete this procurement exercise and select a preferred supplier. So some of the high-level benefits outlined in the paper of EPMA include a reduction in adverse events, where medication errors were a contributing factor, improved monitoring, recording and checking of medications, time saving for clinical staff, improved order management, and a reduction in expenditure on drugs. And some of the benefits of EPMA have been highlighted by the World Health Organization in their report, Digital Prescriptions, and they've outlined how they're good for patients, good for prescribers, and good for dispensers. So the paper sets out a recommendation to approve the full business case and award of contract to our chosen supplier following our Health Board's procurement process. The paper outlines the quality and safety benefits, which have been baselined through significant benefits work that the team have undertaken alongside our pharmacy colleagues and evidenced by research and previous implementations across the UK. And some of these, I'll just pick out a couple of those benefits, is around a 50% reduction in medicine administration errors, a reduction in secondary care Delta parent spend by 15%, and a 50% improvement in administration of time critical medications. In addition, there's some general time savings expected for medics not having to rewrite medication charts, nursing medicines administration, and time spent transcribing discharge medications. And there's also envisaged there'll be a reduction in the annual medication spend by a predicted 1%. There's also some wider benefits around staff recruitment and retention, and also a general improvement in digital equipment across our inpatient areas and improvements in our Wi-Fi coverage. So they still help with future digital development of our electronic health record and also our clinical communications project. There's also significant benefits to our patients through the shared medicines record. So this will be ensure that when a patient's treated at a neighbouring health board, their medication records will be complete, and also that will be available in the NHS Wales app in the future. It's also worth noting this, if the health board didn't proceed with this business case, there would be a disbenefit to our patients, because then when they were treated in another health board, they wouldn't have, that clinician would not have a full record of the patient's medication history. The paper sets out a summary of the cash releasing savings at approximately £466,000 per annum, and the non-cash releasing savings of approximately £764,000. The paper sets out the financial impact of this year as £179,000 for the Health Board, which is then supported by Welsh Government funding of just over £1 million. And then in 25-26, there's actually no impact for the Health Board, but there's significant Welsh Government support of £3.7 million. And then from 26-27 and 27-28, that sets out the funding required for the Health Board of 2.5 million and 2.1 million respectively. It should be worth noting that in total there's 4.7 million available to support this program. Obviously that did not go ahead. So on that funding from Welsh Government, and also from 26-27 onwards, there is a potential for us to bid for further Welsh Government support once the replacement for the Digital Priorities Investment Fund has become clear. In addition, the paper sets out the financial impact of the operating costs of the system once the implementation had been complete, and this includes a permanent product team to manage and support the system going forward to make sure we realise the benefit, and that includes clinical and non-clinical resources. And there's a net benefit to the Health Board taken alongside the cash releasing and the non-cash benefits. It's proposed that the implementation will commence in December 25, following configuration, training, integration and testing. And this implementation will aim to complete by April or March 28. But it will be undertaken iteratively and at pace to deliver benefits as early as we can. I should take this opportunity to thank my team and pharmacy and other colleagues on the extensive work that they've undertaken on this business case. I'm happy to take any questions.
Thank you, Paul. It's a very comprehensive report. I think we're joining and congratulating the team in the scrupulous way in which they've gone about looking at the benefits and actually calculating exactly what they believe will happen. That's really helpful. Are there any questions? Penny and David?
Yes, thank you. Thank you, Paul. I've got a couple of questions. I'll just do one. Why only 50% reduction in medicine and administration errors? That seems very low to me. It's such you know, if you're trying to sell something, just to reduce errors by 50% seems not very efficient.
Yeah, I think that's come out from the research the team have done on previous EPMA implementations and what the benefits have been realised. Clearly, as part of our ongoing implementation and running of the system, we will identify, you know, what benefits we're actually achieving in the health board. But that's come from the previous research that the team have undertaken. I don't know if Jenny or James got any view from that from a clinical perspective.
It's the human error element, because humans will still be inputting data. So you engineer out through an electronic system a number of those potential opportunities for error, but there will still be opportunities. It may well be better than 50%. I think the team have been very prudent in looking at the research around medication errors in relation to EPMA, but there will still be a small propensity for error because you have humans inputting information and data. But we'll continue. What this gives us is an opportunity to continue to look at that. The more we understand, the more we can reduce our errors, the more we can focus on the few that are occurring and find ways to stop those happening. Yeah, absolutely.
Obviously, I'm really supportive of this case. I think it's going to give us a substantial number of benefits, not just in terms of time saving and the reduction in errors and patient safety, etc., but it's also going to give us a bunch of the underlying foundations that we need across the health board. So that's the Wi-Fi, improved technology on the wards that we can then use for other work and other services later. So there's a bunch of underlying benefits we're going to get from this case that aren't just fully wrapped up in that time saving and patient safety as well. The other part of that then as well is the permanent team that this will leave behind and the permanent capability this will leave behind in the health board, a blended team of to get to another piece of work later on as well as maintain this going forward. That's a really important model that all health organisations need to adopt, so I'm really supportive of that. The other thing I wanted to just highlight is the rollout plan. I think is really important. I would obviously like it to go quicker because I think it's really important that it does, but I also understand that they've developed this in the right way. It's an iterative rollout plan. It means that they'll be able to roll it out to a ward, understand the impacts of it, adjust the rollout plan going forward, and then move on to the next ward, and they can test and learn as they go without rolling this out across the entire health board in one go, which would be a huge risk. So it's a really good plan there for rolling it out. So while I'd like it to go quicker, obviously it's been designed in the right way, and I know they've had clinical input in designing that rollout model as well, which I think it's fantastic. And the only other thing I wanted to just call out is that there are set key foundations to sit underneath this. This would be a benefit for the health board anyway, if we were doing this on our own. But there are benefits that come from some of the central infrastructure that we need Welsh Government and DHEW to roll out properly. So a shared medicine record is a key underlying foundational component that allows this information, prescriptions to be shared with primary care medicine and prescriptions and with other health boards and NHS England. So it's going to be really important over the course of the next couple of years to make sure that DHEW deliver their part of this service in the right way. But overall, really supportive of this. It's a really good case. Support it.
Thank you, David. Can I just take up the point about the cross-border issues? Because this came up at a public meeting we had on Saturday in Chepstow about the transmission of information across the borders. Is this going to help?
It is, yeah. So the shared medicines record, the way it's been built is using something called open architecture. So that means there's a defined way where NHS England can request the information from the shared medicines record. So I have checked with the national team and it's clearly on the plan forward.
That's good, yes. That's going to help. Paul,
Can I just say it's an excellent and detailed report, and well done, Paul, to you and the team. I think that's been mentioned a bit earlier. What I think is important is the patients part in all this, and I think it's incredibly important that we will have joined up records across primary and secondary care. And it's going to make great news, I think, for the patients in our area, because frequently time is spent on a patient seeing a consultant or seeing a clinician and explaining all, when actually it'll all be in the records. That should save time and should help in the longer term as well. And so from my perspective, I fully endorse this. The only issue I've got, and it's not to do with this particular project, but a question for Nicola, perhaps not for now, but for later. We've got 3 incredibly important funding elements today in terms of the Grange, the scanner and the digital. I just wondered how this fitted in with our overall position and our overall budget, because obviously these are 3, in my view, must-dos, and the quicker we do it, the better. I'm just wondering, at some point in the future, perhaps we need to understand what we'll not be doing to be able to fund these particular projects.
Yes. Yeah, thanks, Paul, and really important point. So I think in terms of the urgent and emergency care cases, we put aside £3 million as part of a financial plan for investment, innovation priorities. And I think, we've been not agreed many things against that fund this year. I think given where we are, and I think as Neil mentioned earlier, urgent emergency care and where some of our biggest pressures are, this would commit to the worst case £1 million recurrently of that 3, but a small proportion this year, potentially got some opportunities around capital. So I think that fits in with kind of where our expectations would have been, is consistent with the annual plan, but now got the detail. The MRI obviously is a case for capital.
Yeah.
The capital, and then the EPMA, I know we've had some discussions separately as well, but I think we all agree digital is a fundamental area of investment, and whilst it doesn't hit this year, it is a commitment we're making for 2 years' time against our resources. But I think we all believe, unless we invest in some of the digital, I think David's point is really well made. We've had quite a lot of discussion as an executive team, because the case looks more expensive than it is, because we are addressing digital infrastructure as part of it. And you could almost pull that out to say this is a key enabler for many of our other digital systems, and a crucial one in order to take forward a lot of other parts of our digital agenda. So and I think it would, to lose that opportunity of Welsh Government funding support as well on something that's such a key priority. So we've given it a lot of thought, and I think some of the reasons this has been delayed is because we are making sure we do absolute due diligence on these cases before any investment recommendation is made, given where we are financially.
Yeah, well done. Thank you.
Rob?
Yeah, and just to follow on that, there's a table in the paper that describes as a balance of an innovation reserve recurrently. So the first 2 are covered. In terms of the medicine case in particular, it's obviously year 3 of our 3-year plan. It would be marked as our top priority and our first priority against any available funding. That's effectively the decision the board would be making today. But in terms of reflecting on some of the non-cash releasing savings, we should be seeing some positive performance impacts beyond the drug piece. So if there's lots of time saved, for example, on discharge medicines, there's a flow benefit. So once this gets embedded, I think the benefits will go beyond potentially what's captured, and obviously it's important for us to capture and monitor the delivery of all those benefits.
Any further comments or questions?
No, just say obviously very supportive, very detailed case, and particularly like obviously the training and how you're going to roll it out to actually get staff to learn how to do it, and the fact you're trying to get everybody on board, because it's been, unless everybody knows how the system works, I think often there's a reluctance among senior staff not to know and leave it to the junior staff to say that's beyond my capabilities to work out. It would be if I was there, but we don't want that to happen. Everybody needs to be able to access it.
Terribly ageist.
I'm my myself, I'm saying that. Having heard comments from other places where it's, we don't do anything with prescribing now because we don't know how it works. So I think it's really important that the programme of all staff is rolled out. So don't want to get left behind, so I think we
No, we
did
don't.
make a move on this. Thank you.
It's just very briefly, but fully supportive, and very well put together case. And I think the overriding thing for me is, you know, this is going to have an impact on patients, and not just how quickly they move through the system, but it's, you know, if we're going to prevent mistakes with prescribing happening, then we absolutely have to do that.
So are you all content to approve the investment in the EPMA solution in the business case? Yep. Yep. And make sure we trust all improvements in there.
Thank you.
Can we move to the Welsh Language Annual Report, Sarah?
Diolch, Chair. I'm pleased to present our annual Welsh Language Report. The report addresses our statutory obligations in accordance with the Welsh Language Standards to cover key specific areas around the competency levels of staff, the training we offer, any complaints received, and our performance in relation to recruitment. The report covers the period the 1st of April 2023 to the end of March 24. Key points to note in terms of progress over the period: we've continued to increase the recording of the competencies of our staff. We've had new opportunities for learning and support of staff with various language skills, including a Welsh language tutor and an immersive course which some of our staff have been able to attend. We've also had a huge focus increasing our work with schools and young people for our future workforce and understanding the importance of Welsh for patient experience. And we've also been able to increase our compliance with the standards in supporting our digital platforms and systems that have been available. Over the period, we have had a formal investigation for the first time from the Welsh Language Commissioner's Office into two specific standards, 9 and 10. That includes how we allow patients to access a Welsh language service, and standard 10 is around the staff available to deal with that. We were able to resolve the access issues quickly. However, we continue to experience difficulties in recruiting proficient Welsh language speakers, especially within our telephone switch facilities. Although due to the efforts that we've made to respond to that and the continued efforts that we make, I'm pleased to say that the Welsh Language Commissioner's Office was satisfied with our response to that formal investigation. There's more contained within the report in relation to the positive work that we do to increase the competency levels of our staff. And also there are some key highlights in terms of our priorities for the year ahead. Most notably for this year, and a big focus from the Welsh Language Commissioner's Office, is our focus on increasing the number of patient consultations which happen through the medium of Welsh. And with the approval of the Welsh Language Commissioner, we will be piloting some work specifically within speech and language therapy. And we'll be supporting that over the forthcoming months. There's more we need to do in respect of recruitment, and that will be a big area of focus, and there's some detail contained within the report of how we continue to look at how many jobs go out for advert with Welsh as essential and desirable, and how we target the Welsh language speakers within our community to work within the health board. And the report also recognises the importance of the Welsh language from a patient experience point of view. Most notably, if you look at page 28 of the report, page 263 of our board papers, focusing on the good news story, specifically in relation to our Friendly Me volunteer service and the impact that had on patient experience. So today, requesting the board approves the paper in readiness for translation and publication by the end of this month. Happy to take any questions.
Thank you, Sarah. Are there any questions? No? Thank you. So, oh yes, Neil.
Just quickly, which is a suggestion, and I've you might have some input on it as well. I noted about difficulty with recruiting Welsh speakers, which prompted me to wonder whether there are technology solutions which might allow us to work around that obstacle.
There are technology solutions, so we use technology to translate. For example, we will be working with this team over this coming year to use and to understand what technologies we can use to record patient preferences. So that will reduce some of our administrative burden in terms of dual language issues, correspondence going out, for example. But essentially, within the standards, we need to have people that our patients and service users can speak to through the medium of Welsh. And I think that is where we experience some of those difficulties. Although Nicola mentioned the consultant induction yesterday, and it was fantastic. One of the consultants came on to me to identify himself as a Welsh language speaker and can support Welsh language. So, but we do have good success, specifically in the pockets of switchboard, somewhere where we're struggling at the moment, but we've got a number of plans in place to try and address that.
So are you happy to note the progress made and approved the report for onward transmission?
Thank you.
Thank you. Could we then go to the annual quality report 5.3? Jenny?
Thank you, Anne. I'm very pleased to present the board's first annual quality report to you. The board will be aware that this is a requirement under the new duty of quality and duty of candour, which clearly is at the same time as the creation of the Citizens' Voice through FLICE. I'm very pleased that we have been able to present this to you today, because this culminates in a significant amount of work from my team, James's team, Peter's team, but all of our divisional and operational colleagues and all of our executive colleagues around the table. Quality cannot be delivered in isolation, and it is a collective effort on behalf of the Health Board. And I'd like to start by thanking our teams, our staff, our volunteers who have been implicit to some of this work, our patients, partners and stakeholders, because their contributions bring the annual quality report to life. There are just a few things I'd like to reflect on, I think, in terms of the year. We obviously approved 2 strategies which help us to implement the duty of quality. We have a quality strategy which we have refreshed a year on. We have a patient experience and involvement strategy which really goes to how we work with our staff, our patients and our citizens in terms of really understanding their experience of our services. And we've also approved and implemented a listening and learning framework, which is really about going back to the grassroots of listening to people's experience, both good and bad, and ensuring that that's taken forward into how we address quality for the future. We've also realigned our quality patient safety resources. So those are centralised under my deputy, Tracy Partridge Wilson. We've realigned them in the beginning of this year, and we're now currently going through a redesign and re-engagement process. We've increased our QI capability. We've very successfully delivered our ambitions as part of the Safe Care Collaborative, and we look forward to the new iteration of the Safe Care Collaborative, which will begin in October. We've launched ward accreditation. We have accredited our first ward, and many of you will have seen that on the carousel recently. So A2 achieved bronze accreditation, and we have now about 10 wards that are due to come through at any point. As you'll know, we aren't going to make that just about nursing and wards. This will be an approach to accreditation for all teams across our multi-professional basis. But that means that teams really understand their data, they really understand their audits, and they really turn that into improvement. We've produced, or James has produced a learning from deaths report based on the English model, which really goes to much of our mortality data, but most importantly, our learning. And I think we're the first in Wales to have produced that in that way.
We've continued to focus on falls and the work that we're doing to ensure that people are safe in our environments, but through that focusing on enhanced care and a new enhanced care framework and some of our assessment processes. And that's been enabled through the Welsh Nursing Care Record, which I'm very grateful to Paul's team to helping us to implement, that we've rolled out over the last year, which enables us to really understand the assessments for falls and if those are being done in a timely way. We've also really looked at how we listen and learn. We've got focus work this year on drawing in that positive feedback, but we've started to enable ourselves to understand experience in a way that can turn into learning. So we've created a learning repository. We have a new learning and improvement group, which engages with our teams across the divisions, across my team, James's team and Peter's team, in terms of how we turn that into capability and improvement. You'll know that our golden thread for quality is our pillars of quality. And whilst you'll see our quality report for Q1 is still based on the health and care standards moving forward, we've redesigned our quality outcomes framework to really focus on how we are responding to what we have said are our greatest areas of quality improvement need. So those are infection prevention and control, patient experience, how we manage incidents within that, medication incidents and other incidents, health and safety, and the many improvements Peter's led, safeguarding, and our work on concerns, complaints and compliments. I just want to mention very briefly our key work streams for 24-25. So we are going to continue to refine our quality reporting structures. That's not just about the quality outcomes framework, that will be about how we draw up intelligence learning information into our overall understanding of quality assurance. We are looking at our data and working with Lloyd's team to see how we automate some of that in a way that enables us to be more fleet of foot around pulling that data forward. We are going to focus on sepsis in this year and deterioration. That will form part of the Safe Care Collaborative. And James and his team will lead the work that refocus our attentions around sepsis. We are also going to focus on infection prevention and control. Many of you will know that despite the really great work that has happened over the last couple of years on infection prevention and control, our rates are not what they should be. That's not an Aneurin Bevan issue, that's a Wales-wide issue. And we're really connecting the antimicrobial resistance prescribing and some of the work we need to do around going back to the basics of infection prevention and control. And finally, our fourth priority is really around the human practice programme. We know that human error, and to err is human, has an impact on our safety measures and our safety, the safety of our patients. Even when we automate, we still have human error, and human factors is going back to really understanding what we can do about that. We know that system and process tends to lead to human error. So human factors enables us to really pull that down and to think about what the tangible actions and improvements we can make to engineer out human error. And thank you, Chair. I'd just like to commend the report for approval.
Thank you, Jenny, and thank you very much for all the really hard work the team has been undertaking to refine this and to give us a very clear statement of process. Are there any questions? If not, I know it's been scrutinised thoroughly. So we'll be happy to note the progress and to approve the report. Oh, sorry.
No, I haven't got a question. And yes, absolutely excellent report, excellent. I just wondered whether PQ SOC could be mentioned. It is mentioned. It says we provide assurance to, but I wonder if a bit more could be put in there about the scrutiny purposes, so that the public can see the relationship between the two. Because I noticed in the audit report that the Audit Scrutiny Committee is mentioned quite a lot, and it just refers to it. And I just thought, you know, in terms of such as noted by, or recommendations as noted by PQ or recommended by PQ and so on. So I just wondered if that could, going forward in the future.
It's an Irish report. Yeah, absolutely.
5 for commissioning of the quality approach.
Thank you, Anne. So again, this is a relation of activity between myself, James, Peter, and Rob's team in finance. As you'll know, commissioning is an important part of the health board's accountability and responsibility. And under the duty of quality, there is a requirement for us to understand the quality of the patient experience, the patient safety, and the effectiveness of the services that we commission. So this has been, we have put this together as an approach. So this is about really starting to try and understand the work, the contracts we have for services within the health board. But underneath that, how we will start to pull together what our understanding is of the quality of care that's provided by those providers. We have some information in some places, but that isn't collated in a overarching approach for the health board. So we've had a working group that's been trying to look at those commissioning for quality processes. We've set out an approach in the document, and really I just want to mention to you the couple of things we're going to do moving forward. So we've already started to benchmark and draw in an understanding of where those contracts exist, and that work's already started. And we've been doing that work in partnership with Rob's team to create a central repository and map of where commissioning services are. But underneath that, what we want to do next is really develop a small commissioning working group to start to think about what is the information we need, how do we report that for assurance within the health board, and how do we continue to develop our understanding of quality across the totality of the services that our citizens access. So I won't say any more than that, and the approach is there for you to approve, and we'd be seeking your endorsement for this approach.
Are there any questions?
Thank you. And as a broad approach to commissioning, I think we've had conversation before. I think it seems very sensible, very sensibly put together. Do we have any idea at the moment so far about what the kind of breadth of the commissioning is, or is that part of what the working group is going to come back with, and when do you think they?
Yes, we do. I think Rob's team have a really good understanding. There is Anne-Marie Matthews, who has designed the framework, who sits in James's team again, has a really good understanding of some of our IPFR processes. I think what this does is bring it together and actually then start to think about how can we provide assurance to PQSO through to board on the quality of our commission services. So we're not starting from a basis of zero. We've actually got a lot of work that's already happened in the health board. I think what we're trying to do is really start to strengthen the quality element of that.
That's good. Thank you.
Yeah, I'm just thinking about it. I mean, this is such a good initiative, really. We do a tremendous amount of commissioning, but actually, when we've got the skills to do it, at times, I guess, is probably why we're now reevaluating what we're doing. I'm just thinking about whether we can make connections across the piece with this, particularly with councils, for example, in terms of the amount of commission they're doing and the amount of commission we do together. And even if you look at the recent partnership board, we commission partnership board, 20 million pounds worth of services at least every year with very basic commissioning skills. So I just think as this is such a good initiative, can we get as many people in the initiative as possible?
I think that's part of the work we need to do. And many of you will know I spent many years as a commissioner in England, so I have a strong view about the value of commissioning. And I think, this you need to take an overarching approach. We've started with quality because in some ways it gives us the opportunity to ensure that we are really clear about the quality outcomes for our citizens. And we've got some really great examples. For example, continuing healthcare, they have really great relationships with social care. They do that on a broader basis, and actually they have a really good understanding of quality. That's not the case in every service we commission. So I'd see this as a starting point. Phil and I agree. I think there are opportunities for us to look more widely in terms of our commissioning approach as a health board.
And it will correlate with the JCC.
And I think
they need to tie. We need to learn from each other.
We do, and I think there's also something about how do we draw in the quality information they hold.
That's right.
And how do we ensure that that connects with the information we hold around patient pathways, around the other services we commission, but also provide.
Yeah, because the chairs are working on how we will hold JCC to account for our population's service.
Just a quick comment. Safeguarding is vital, of course, across the board, isn't it? So how do we ensure the safeguarding process of those we commission? I know that in local authority, we keep a close eye on it, and I just wondered if that's incorporated anywhere.
Yeah, absolutely, Penny, because it's one of our pillars. So when we look at how we're going to commission for quality, safeguarding is one of our pillars. So we'll commission it. We'll certainly design our framework around the pillars to make sure we can draw that through.
Are we happy to approve this? Thank you very much. It's a real step forward. Thank you. And might we break for 10 minutes, please? Just copy that.
Yeah.
Copy and copy that. Oh, obviously that's been covered. That's over the years. I've always been better. We talk to get having expectations to play. Very long so much. And one more time.
It is extremely question about like this engineer out in the farm, but can't quite. But I think that for nursing.
Thank you for agreeing with to having a break. Can we continue, please, on 6.1, the performance reporting integrated performance report, please.
Yeah, thanks, Chair. So colleagues will recall from the July meeting that we set out our intent to sort of try to move towards more integrated performance reporting. So this Q1 report seeks to do that. Because it's Q1 as well, it's also got the addition of updates against milestones that the plan committed to. It's important to do that on a quarterly basis as well. So slightly longer than the usual monthly performance report. Recognising as well, because it does just go to Q1, some information to update. So I just want to update and draw a few elements of the report and update with some up-to-date information where relevant. I was only going to draw out some of the operational performance issues because colleagues, Rob and Jenny and others will be following on with their more detailed reports. But for completeness, you have the integrated report that went to the Finance and Performance Committee as well earlier this month. So just some key areas, starting from sort of prevention then. So from a best start in life commitment, the baby checks at 8 weeks, which is a really important measure in terms of that interaction with babies and families in their early years. So that is continuing to increase for the last 7 quarters. Still further work through the Health Services Improvement Plan in train to improve that further. And also to note that our contacts in primary care, we are currently ahead of exceeding our planned levels in
GMS, optometry, dental, and still see the same improvements in the common ailment scheme as I reported last month. Onto some other areas then, just to draw out. In terms of cancer, in June we did see a bounce back of single cancer pathway performance to just under 60%, which was just under 50% in May. And whilst the August position won't be finalised till the end of September due to that ongoing validation, the expectation is that that is another improvement on the 60%. And as the work that's happening through the tumour site task and finish groups is starting to bear dividends, new pathways, the postmenopausal bleeding pathways, new modelling breast, and focused endoscopy pan support colorectal is really starting to reap the dividends. So positive in that respect. From a plan care perspective, I think as Nicola touched on in her opening, this is a big priority for the Cabinet Secretary. We continue to make good progress on our ambition to eliminate waits of over 3 years, so 156 weeks. The report shows that we had 47 patients waiting over 3 years at the end of June. I'm pleased to say that as at the end of August, this is at 18 patients with a prediction of 14 at the end of September and 0 at the end of October. So that's real credit to the targeted sort of focus and interventions that the teams are putting in, particularly in those 3 specialties that we've reported on previously. So the ENT progress, those patients are cleared now, is focusing on the particularly patients. So that's positive. A big within the planned care sort of suite of metrics, 104 weeks is another key focus, and total waits of 2 years. The Q1 position was ahead of the trajectory we set ourselves in our May submission. In June, this was at just over 4,400. This is now down to just over 4,000, 4,018. So we are ahead of trajectory and a continuation of the progress. Just to note against this metric, Welsh Government did request a submission for further opportunities to go in further in terms of the commitments we set out in our May submission. Were additional fundings to be made available? We did put that submission in at the end of August and are still waiting to hear back. But I think that the fact that we're delivering ahead of what we said is surely going to help in terms of giving confidence that we're delivering what we said we were going to deliver. So that's really positive. We've picked up diagnostics, a bit of a theme in earlier conversations. We continue to make the progress in reducing those numbers waiting over 8 weeks. Again, at the end of Q1, that was at 4,222, but pleased to say that improvement continues and is now at the end of August at 3,600. Huge focus in the area of endoscopy to try to recover the position where capacity was targeted at cancer, recognising the urgency there, and very specific plans and some diagnostics such as neurophysiology. Our biggest challenge in the planned care space is in outpatient waits. We are off our trajectory in terms of numbers of patients waiting over 52 weeks or waiting over a year. So we're around 16,900 against a plan of 15,100. Actions include what we're doing around some processing in terms of validation, but pathway improvements using the Health Pathways platform, GP gatekeepers in some specialties. So that's the areas causing us the most challenge at the moment, but noting good progress across a number of planned care elements. From a mental health perspective, we've previously referenced some of the challenges in that service, but again, good progress for adult mental health in terms of the assessment. So the Part 1A, again, ahead of where we said we would be, and August has gone up again with the report to 64% and with high levels of confidence to hit the 80% by the end of December, using a sort of a suite of actions, both sort of pathway but process as well. This team have used RPA to help speed up the referrals, which has been successful, which is worth us coming back to in the future session. Again, improvements we've had in August on the adults 1B from 17.9% in June, that's now at 22%. So still off the national standard of 80%, but with plans in place, including counselling and a very successful validation exercise
to continue with the trajectory we've set ourselves. Just to draw out a few things from a CAMS perspective, neurodevelopment has been an area of focus. Again, compliance gone up from the 38.5% in the report to 43% in July, and an improvement plan to further increase that we've previously explored and supported by execs. This, in addition to targeted investment, is continuing to sort of deliver through new pathways and the focused work with cross community paediatrics as well as the CAMS service. Good progress there. Urgent and emergency care, finally, then, in terms of drawing out, we've touched on it a bit in some of the earlier items, continues to be a real significant level of focus. I said, as touched on through the weekly oversight meetings, Leanne chairs, but with a number of us execs also present, and the monthly oversight from Welsh Government through the enhanced monitoring arrangements. Important to note just on this, we find ourselves awash with measures and trajectories in urgent and emergency care, from hours in the plan to then the ministerial targets that came afterwards to our escalation measures. So we are doing that reconciliation to try to bring those all together, really. So we're just clear on the various metrics and trajectories that we're being held accountable for. So there are a suite of actions against those key areas. The recent data in the report is showing an improvement in a number of areas. So handover delays over an hour, and the improvements were noted in the Welsh Government escalation meeting. I think the challenge, as we all recognise, is the sustainability of those improvements. August has been a very challenging month in terms of that metric. So we've seen deterioration in August from the June and July improvements. The 12-hour ED wait, patients who are waiting more than 12 hours in ED. Again, this is a metric in our enhanced monitoring arrangements. But that is shown an improving picture from nearly 1,600 in April 24 down to just over 1,200 in August. And the actions, I think some of them were clearly picked up in the earlier paper in terms of some of these system actions, but there is still a suite of very focused process improvement actions, from how we record the handover with the dual reporting request to the learnings from the GP in Front Door and in ESTEC, and the work that Leanne and her team are doing on the operational framework in terms of the escalation metrics, triggers, and interprofessional standards in terms of responsibilities and accountabilities of other specialties that we do at the Front Door. We received at the Finance and Performance Committee the action plan around the de-escalation metrics. So I'm conscious there's a lot of information in the report, but just wanted to draw out those updates from the data. I'm happy to take, or should colleagues happy to take any questions. Thank you very much.
Are there any questions on this set of data? Pippa?
I just have one small question, and I noticed in the pack, I think it's I had it written down as page 382, but the page number's not important. It's about compliance with GPs reporting and childhood vaccination figures. So I just wondered whether or not, if we're not getting all of the GPs reporting into us, are we sure about the numbers that are getting vaccinations?
I think I'd have to double check that, Jenny. Sorry, Pippa, just in terms of the timescales for those actions and the quantum of GPs that we've got concerns about in terms of reporting. So that's a big else has got.
Do you know, Malcolm?
I can come in as well. So there's the national data, which is the cover data, which is validated, which is obviously not real time, and that provides a sort of baseline measurement at GP cluster level as well. And I think that the work that Hannah's talking about is about that more real time work, which I know is an ongoing area of work with the population health team as well.
Just to add, it'll be a feature, obviously, the deep dive we're doing into children and young people from the November board. And obviously our new strategic children and young people's board starts on Monday. But the inaugural meeting, vaccinations will form part of that vaccination improvement, which because Tracy and I are chairing that joint.
Oh, good.
Thank you, that's really helpful because it's just vaccination is such a key thing, isn't it? So thank you.
So that one of the biggest challenges is outpatient waits. Is that just for that small group of specialties that are, you know, the ENT, ophthalmology, or is it more widespread?
So there are, I think it's important when I talk about presentation of the data that we recognise that there are a lot of specialties that are delivering and sort of managing to better match the demand and capacity. So, you know, whether it's a future report to draw out some of those areas that we just acknowledged where they're keeping those weights down. It is for the 52-week wait, so it is more than just those three specialties, but they are predominantly in the surgical specialties area. We do have some few sort of emerging challenges in some of the medical specialties, endocrine, for example. But the team, through Leanne's team, the focus on regular RTT meetings where those focused plans on specialty levels, the over 52-week wait outpatients is more than just those three specialties, although they do make up the biggest portion.
Do you want to add? Did you say on that? I think there's 7, isn't it? So it goes from 3 at 104 to 7 specialties pretty much. So there are a few stragglers, but there's still the majority of specialties will be delivering, but there's about 4 or 5 extra specialties in that.
Yeah.
Some of the Charles, Hannah said in the surgical area.
So urology, general surgery, a bit of max fax. When you start to get further down, you get some more challenges of that. Yeah.
Thanks.
I just wanted to mention about stroke. Stroke indicators are included in the report, and all will be aware that we've been very challenged around our 4-hour target to when patients arrive at the hospital to get into the ICU. We've done a lot of work over the last 12 months as part of the stroke improvement plan on the back of recommendations from our GIRF review. Whilst some of that front end performance is very challenging, are beginning to see some green shoots of early improvement, particularly from a pilot that we've implemented at Grange through the months of July and August, although challenging and lots of learning from it. One of the indicators that's really pleasing to see now coming through is the results from our participation in a national UK audit of stroke that we participate in, as do all health boards and trusts. And we have been really challenged in the audit. We've been scoring at E and D over recent years. I'm really challenged to get our stroke performance up. And I'm really pleased to say that the most recent performance report from the national audit has scored us at a C. And it's the first time that we've been back at that level well over 2 years, before the pandemic, actually, since we were C. Our ambition is to get to B and even A, of course, and we continue to implement the improvement programme stroke around that. But I just wanted to share that good news that some of those green shoots from our improvement plan are beginning to show.
Good. Thank you. Are there any further questions? Louise?
Yeah, thank you, Chair. Hannah, I'm just wondering, thank you for the update in the report. I'm just wondering, was there any update from the last board for the date for the public consultation as regards to the stroke move? I know you were still looking into it last time, but the yearly date is quickly approaching, and I think staff are probably aware of that. And I just wondered what the update was on that, please. Apologies if it's already been set and I've missed an email on that. Thank you.
Yeah, so happy to. I'll start. I'm sure Leanne will come in. So no, we're doing it in terms of we've been received in a recent executive an update on the position from stroke in terms of the months it's been running, and starting to form and test a view in terms of the sufficiency of information and the amount of time it's had to sort of bed down. So the short answer to the question is we haven't set a date to do formal public consultation on this yet. And we need to just sort of review where we are in terms of the length of time we've had to run the change, and have we got sufficient information to make a decision either way, and also conversations we've started but not concluded with Llais on how the opportunities to do a comprehensive piece on engagement and consultation around changes more broadly in the context of Neville Hall as and when they start to emerge. So the short answer is no, we haven't set a date yet, but that's some of the sort of rationale for why, in terms of the need to link with wider changes and as we start to see more information on the impact of the changes to date. Did you want to add anything, Leanne? The intention, Louise, is to bring a comprehensive update that covers off all of those things to board in November, but happy to have a separate conversation sort of outside of the room ahead of that if there are any particular concerns.
Yeah, but that would be very welcome. Thank you very much. I'm just wondering, we're constantly talking about the wellbeing agenda for our staff. I just wondered if this is a time when we should be updating them on before we go to public consultation, because obviously staff are starting to ask us from a trade union perspective. So that's why I raised the question.
Yeah, no, it's really important, Louise, and that will be done. Are there any further comments? I think what strikes me within this report is the mental health performance, and I think we should have a finance and performance committee, please. The full explanation and action plan for improvement.
Yes. So there is a very clear trajectory for improvement from a mental health and healthy perspective, both for adult and CAMS, noting our performance is less than ideal. We are delivering to the trajectory that we have set and have seen quite significant improvement, certainly since the start of this year. It's micromanaged. There's a fortnightly meeting that the Deputy co-chairs, in particular in relation to the adult mental health sort of piece, and a weekly meeting on CAMS, just to focus on that. But more than happy to bring a more detailed briefing sort of that outlines that.
Yeah,
It's very board will also be very well with the impact that WICIS has had from a service perspective. So in part, this is in part a legacy, albeit there are some performance issues within the division that we board will be aware of, and we have been working through.
I think we need to unpack that because we're obviously going to be tested. Thank you. Lisa?
Thanks, Anne. Sorry, I was just going to pick up in terms of Llais engagement around the temporary stroke rehab arrangements and the proposal to extend by up to a further 12 months, just for reassurance really that we are tightly glued into where the team are with regards to their thoughts and proposals, and have shared with planning team within health that we're happy with this proposed extension, subject to regular monitoring of any travel access issues or concerns that may arise, a commitment to the wider public engagement exercise, as you suggest, Louise, in respect to the final permanent options and the model once this has been finalised. So I just wanted to share that with individuals in the room really for assurance. Thank you.
Thank you. Thanks, that's helpful. Any further comments on the integrated performance report? No. Thank you very much. Could we then go to policy outcome? No. Policy outcomes and performance report. I've turned my page over. That's fine. Yeah.
This is the Q1 report. Many of the things that we're focused on, I've already talked about in the presentation on the annual report. So just a couple of areas to mention. The first is around patient experience. Clearly, our satisfaction levels are 90% in terms of patients that do respond by Civica. We know that we have more to do in terms of certain groups of patients having access to a more user-friendly response to Civica. So we're investigating the text option with a pilot in the emergency department to enable us to receive more results, but pleasing on the results that we do receive overall. We
We do well against the duty of candour, so we had 18 incidents in Q1. I should make the board aware that we can't yet report compliance because of a change needed in Datix. So we can report on the numbers that trigger duty of candour, but not compliance with timescales as yet. But that requires a Datix change, which I will bring an update back through to PQSO on when that will be in place. But that's an All Wales issue and well discussed. Our RAMI has continued to drop below the All Wales mean, but that's around 107. And as I've said before, we have gone over and above with our learning from deaths approach. We continue to see a rise in our infection rates, particularly C. difficile and Staph aureus. We've taken deep dives back through the executive committee, and James and I are now chairing an enhanced oversight board to bring together works that is required on antimicrobial prescribing, but also, as I've said before, on some of the way in which we need to refresh our approach to management of infection prevention control in our environments. Unfortunately, we've had a total of 540 incidents attributed to aggressive or threatening behaviour towards staff. Peter may want to comment on that in a moment. There's a programme of work, zero tolerance, looking at how we start to address that. And in terms of safeguarding, we have seen quite an uptick in reporting. So 41% rise in adults, 13% in children. We have done lots of work on awareness raising. We have a member of our team now who's embedded with the urgent care ED division, who sits actually alongside and with them. And we have seen a rise in reporting. I'm not concerned about that because I think that's due to the work we've done around increasing our uptake of training at level 1 and level 2, our awareness raising of when safeguarding issues should trigger. That does cause a capacity issue for the team, because obviously they have to report all of these and manage them through with our local authority partners. But nonetheless, it's pleasing that we've seen that uptick and rise. You'll know in terms of the work we need to do, we continue to need to improve on level 3 safeguarding training. We have improved slightly over the quarter, and we've been providing bespoke training to both mental health and learning disabilities and maternity. So we're trying to flex the training for level 3 to make sure it's much more relevant to service areas. The tricky element with level 3 is an element of it has to be face-to-face, so it can't be all online. But we're obviously managing that in a slightly different way, and that's been well received through our divisions. Peter, myself and James continue to focus on falls. We know that there continue to be injurious falls in our environments that are preventable, and we continue to focus on that through our quality improvement work, but also how we're embedding the new enhanced care framework and something called SWARM methodology, which is about how you gather around incidents and pick forward the learning. In terms of deteriorating patient, we know the new Safe Care Collaborative is going to launch in October. We very much champion the work around deteriorating patient. Our focus will be on sepsis, but that doesn't mean the other elements of deterioration won't be addressed. And we have a new approach called Call for Concern. That builds on Martha's Law, and some of you will know about Martha's Law, which obviously started in England around that second opinion for families who are concerned about their loved one. So that started, and we're beginning the rollout with that process across the health board. The final thing I'd say is that we know we are not where we want to be on putting things right. We haven't improved our performance over the quarter or even over the last 6 months. We have a rise and then we drop back. There is a bit of an issue around as we focus on the aged complaints, which we've improved significantly on. Obviously, our in-compliance performance drops. So we are still aiming to get to 75% within 30 days. I've pushed the team to deliver that as soon as possible. And I'm hoping that we'll at least be at 65 to 70% by the time we get to the end of October. So further work to do, great divisional support. I'm pleased to say we've improved our early resolution performance. That's nearly 80% now, which means we're intervening much earlier with families and getting those concerns concerns resolved informally. What we've got to do now is to get down our complaints that are over 3 months old. But as I've said, we've had fantastic engagement from our clinical colleagues in trying to do that, make sure that we are really focusing on what the needs of the family or the patient are. We've introduced an acknowledgement team, so we get the questions from the family straight right up front. So we're not sending a very long response, which talks about a timeline of care but doesn't answer a question. We've got that engagement first off with families. So I think I'll pause there.
Are there any questions or comments?
Just say, great stuff, great report, I thought generally, and it's just the direction of travel is clearly now crystallized on what we really mean by quality and outcome, isn't it? Which is really good. I just wonder whether on some of the metrics we should be using a bit more benchmarking so that we know where we are.
Yeah.
I mean, the safeguarding one is an interesting one. It probably is a result of training and all the rest of it, but it would be good to have some kind of assurance around that, along with some of the others. Because sometimes a straight kind of figure is not as relevant as saying where we are relatively well.
Absolutely, Phil. And there is, so for Q2, you'll see a new style quality outcomes framework. I should say that we've been through an iteration of what absolutely needs to be embedded in a quality outcomes framework. I think we've got too many metrics at the moment. So we've really honed it down to, what we call our vital few. There's also a piece of work I'm involved in, which is a all Wales quality outcomes framework. And I think that's where our benchmarking data will come from. It's been very difficult to extrapolate some of the quality benchmarking data at the moment, but that will come through the new quality outcomes framework on a all Wales level.
Benchmarking's a knotty area, Phil. Who would or what would you benchmark against?
Well, I guess if we're almost pioneering quality stuff across Wales, aren't we? So I suppose I guess other people will want to copy and look at what we're doing, so that we can actually get similar matrix that we measure against. So I guess if we started on a fairly low base, I guess it will develop. And there must be other organisations nationally that are perhaps in England, I don't know, more than I judge really. But
the reason I was asking is if you know who the best is, then absolutely we should be benchmarking against the best.
Yeah.
But if you don't think anyone is performing well, then you should set the benchmark where you believe the best interests of patients sit, even if no one is against it. But I think the way in which we're presenting data in a kind of run chart so that we can see trends is real progress. And I agree with you. I think maybe the next thing we should be discussing as clinicians in Wales is where are we heading? How will we know?
Yeah. I mean, if we take the safeguarding issue, for example, to the All Wales Safeguarding Board, they will exist. To be a good conversation with them, to be asking the kind of questions that we're asking. You could almost develop a benchmark from that.
I mean, there are some like RAMI, where we can, the infection rates. But obviously, you're comparing a little bit apples to pears because of different size of organisations. But as James said, it's where we want to get to. I think some of that will come through the new National Quality Outcomes Framework, and the focus will be around avoidable harm, and safeguarding will be part of how we start to try to pull that forward on an all Wales basis. But it's quite tricky because when you look at health boards and the scale of the services, and you do that on an all Wales level, it's really difficult to come down to a small number of metrics you're going to get absolutely right, because everybody wants their metric in. So we've had to go through that process, and I think probably the Welsh piece of work will too, because you've got to make sure that you're focused on what the purpose is, and our purpose is to reduce avoidable harm at the end of the day.
Yeah, well, I mean, it's all complex stuff, isn't it? And the more you measure, the more you need to measure. That's the problem, isn't it, really? But I mean, this stuff has been in the too hard tray for a long time. Once you start to get out of the too hard tray, you realise why it's been in there.
There's a great danger of, if you create an all Wales metric that measures one thing, buried within that metric, there may be great performance for someone living in a rural area of Powys and terrible performance for someone living in an urban area of Newport.
Yeah.
So we have to make sure we've got enough granularity so we understand that we're meeting the needs of every citizen.
I think it's actually been covered. It was along the similar lines of what does good look like for a lot of the metrics. Yes, it's great that we're seeing this improvement, but to be reading it cold, is that good or is that can we do better kind of thing. It's where do we draw that line to say, yes, now we're into the bracket of, we can almost forget about that one and concentrate on the next one to push up the line. And it's identifying those, and that was, I find a little bit difficult to do.
We say that will be part of the next piece of work we do. And I think, you know, we need to be clear about that internally. I think there's something about that one on all Wales level. And then how do we look into England and then globally potentially? There are really good examples globally of organisations that have reduced avoidable harm. So I think there are opportunities. But you know, I think we spent a while getting it right for us. And as I say, our quarter two report will look very different because we've really started to focus on what are the real tangible things we want to focus on.
It's been a fantastic exercise, and I think one of the things I learned from when Tracy first arrived is her reflection was that we have a lot of data and not much knowledge in the health service generally, and it's been a fascinating journey going from converting data to knowledge that allows people who set strategy and deliver clinical care to actually know what they're heading for. This is a really helpful discussion, actually.
It's great knowledge to share with staff, isn't it?
Yeah.
Yeah. I mean, staff will to know how well we're doing, where are we? I mean, they're basic questions, really. So that, you know, you complete the whole circle on.
When we talk to you next month about the quality improvement strategy measurement, will be a big key part of that, because you can only improve if you can measure.
Yeah.
So it's how we focus it on an improvement methodology approach, and encourage all of our staff to understand their data and to know how to improve. That's where we'll see the tangible change.
Yeah. It has to be relevant for people as well, doesn't it?
Absolutely.
The odd themes, it needs to be relevant for people on the ground who understand it. We don't want to make it all sound down the brains, do we?
No. So.
Yes, and obviously I've seen through PQSO, I've seen this report develop, and I think, you know, all credit, there's been a huge amount of work that's gone into this, and to Jenny and her team, and actually Peter and James, the amount of work that's gone into us being able to look at quality in a different way, I think. And I think one of the things that I wanted to just reflect on is that it has changed and is continually changing in order to meet the needs of the organisation and of our patients, so that we're able to provide better quality care, and so that people are not coming to harm within our care. And I think that's one of the most significant things that comes out of it for me. So I guess I don't see it as a done deal. I see it as an improvement process, this whole report. And I just thought it was worth noting that we've come a long way and the team have done a lot of work. I look forward to the next iteration.
Thank you. Any further questions, comments? Thank you very much, Jenny. It's a really helpful report and a great improvement. Finance performance.
The report included in the pack for today is the financial performance report for 5 months ending the 31st of August 24. In terms of an overview, in terms of revenue position now, we've got a revenue deficit year to date 22 million. Forecast of £47.8 million deficit, which holds our floor position, which was an improvement of £1 million. In terms of capital, we've spent £29 million a year to date, which is about 45% of our funding, 64 million. And that's actually quite positive. Historically, most NHS organisations have to rush through spend at the end of the year, but we've got a good measured plan going through and being delivered for that with a forecast of break even. In terms of our public sector payment policy, we're in at 97% of paying our creditors in 30 days against the 95% target. And in terms of cash holding targets, we concluded with 5.2 million cash out at the end of the month, compared to the £6 million target set by Welsh Government. Our underlying position is continues to be a reported deficit forecast of £55 million. So quite a stable and expected position overall for month 5 in terms of supply. In terms of key points, so we have assumed income retention of the Welsh Government conditional funding, 65 million, as we have done previously. Real living wage funding and CHC funding through of £4 million. We've anticipated some additional funding this month to do with optometry, GP prescribing cost code, PABMs, and some international recruitment funding, 2.8 million. And I'll come back to that in a moment. In terms of pay spend, we continue to spend each month less than the average for last year. £66.8 million spent in month 5, slightly up on month 4, but month 5 was a 5 month, so we've got additional enhancements coming through and some substantive recruitment, which is a positive. Our variable pay position continues to be well below last year, so we spent £6.7 million in August. That's slightly less than the months before and compares very well to the over £7 million we were spending on average in 23-24. So again, that's reflective of all our efforts to reduce our variable pay bill. In terms of non-pay, we had an increase in month 5 over month 4 of £2 million, but that was because during month 4 we did spend and allocate to our NHS providers the pass-through of the wage award directed by Welsh Government. So there's a movement in month that isn't representative of more spending. Both run rates for pay and non-pay are in the report. On average, are generally flat, and on average, they're running broadly in line with expectations. So again, a positive, and also provide some confidence in terms of delivery of our forecast overall. In terms of savings, we've got a forecast savings level of 43.4 million, which is above the £40 million target we set in the plan. £34 million of that expected to be recurrent. Again, that's a positive impact and it's above our original plan. 38.9 million of those schemes are ranked as green, 4.5 as amber. We are doing a review ready from the 6th in terms of seeing what we can move some money to green, just to make sure we've got the absolute clarity on our position. From a year-to-date perspective, our savings plan expected for month 5 was up to £11 million. We are reporting £13 million actual savings. So again, over £2 million favourable position on those. So overall, as an overview of where we are year to date, again, it's also got the line into the plan and quite positive. In terms of our forecast, whilst we are holding the 10.8 million position, how we get there is slightly different. Page 4 of the report provides a summary table of the changes between months that shows how we are holding our forecast. So most notably, we've recognised some price changes in our prescribed drugs and also some nice pronouncements that have come through. So overall, our drugs increased forecast is about £4 million. That's been offset by the recognition of additional income, which we do need to get confirmed from Welsh Government. The following meeting this week looks likely. I'll come on to that in a moment. But we've also brought in the additional savings we will be expecting now from our CONTAF contract, LTA contract, where there's under delivery for the year to date, and the trends indicate a full year under delivery of approximately 1.4 million. We still do have some issues with agreeing the CTM LTA contract, but we believe we're in a strong position to recognise that, and that's aligned with the guidance provided through the arbitration decision through Welsh Government for this year. In terms of operational issues, we continue to have high levels of delayed transfers of care, 319 at the point of reporting, with 25% of those being healthcare related. In terms of activity, we've continued to deliver elective and urgent care, as we always do. RTT targets have obviously been invested in. We've used some of the innovation fund for that. But we've also got additional WLIs running, waitlist initiatives running to support our cancer agenda. And the funding for that is basically offset in reserves at this point in time. In terms of our reserve position, as we discussed earlier, We currently have £1.8 million uncommitted, which is the innovation reserve. And given the conversations and decisions earlier, that leaves us with probably about just over £1 million left for this year as uncommitted for additional contingency issues or decisions we want to make. Monitoring returns are included for information as an appendix. I'll pick up on a couple of other things that would be of relevance for the board. So we, through our escalation and performance framework, we've held finance escalation meetings with some budget holders to see what we can do to progress achievement of savings and achieve budget financial balance in the overspending areas. And this week there was a target intervention month 5 review with the with Welsh Government Finance. They're broadly content with our position. The message is for us to absolutely achieve our forecast and obviously go further, which I'm sure that's not a surprise. But we do need to land our forecast and not go off that, otherwise that will be a problem. So that's it really. That's an overview for month 5 year-to-date forecast and the reports for sure.
Thank you very much, Rob. Very clear. Are there any questions? Can I ask then, why has there been a drop in Step Closer to Home from 49 to 6? It seems quite an excessive drop, particularly as this is one of the schemes on which we rely for ensuring that people get optimum care in the right place.
So I'll probably defer to somebody else to give a more comprehensive response, but in terms of it was identified that we actually got one patient using it a couple of months ago, so we've actually increased that usage. My understanding is an element of the service requiring a follow-on service provision through local authority social care. It's been a bit of a pressure point. Like I said, it was down to 1. We are seeing an improvement at this point in time. I think, as you've just described, it was an investment through the RPB to help delay transfers of care and put people and citizens in the best place for their care. But as I said, the social care challenges we've seen in general, delay transfers of care and provision of community social care appears to be a challenge. I don't know if other colleagues will add to that, but that's my understanding of it.
Anna?
So yeah, to just it sort of links with some of the conversation we had in the RPB yesterday. So in terms of the slippage to support the system resilience plan, which because I guess the positive thing is yes, use has gone down, but therefore spend has gone down. It's not got fixed costs within it, so it's on a spend per case basis. Because there's that sort of a hypothesis that that's because the sector in terms of dom care is in a better place, so the need for Step Closer to Home is potentially less. So working with, I know Jenny through the integrated discharge policy, so how can that slippage and opportunity be targeted at areas, whether it's hospital to home, where we know there is still a demand and there is a need to reinvest that slippage. So that's I'm going to come in on that, but that's part of that system resilience plan conversation we had yesterday.
I think there's a patient choice element as well, because Step Close to Home is obviously utilisation of care home beds, and patients don't want to do that; they want to go home, which is why I think it's sensible for us to look at how that slippage is used to enhance some of our other schemes, which are about caring for people as close to home as possible. And I certainly spoke to Lloyd about it yesterday, the Divisional Director of Primary and Community Care, about how we might start to do some of that to enable that transfer back to the community rather than into a care home. But the choice is definitely a factor.
Fine, good, okay. Just as long as we don't lose track of it.
But the important thing is resources there to help.
Yeah, quite.
So
Exactly. Are there any questions? No?
Okay, thank you very much. Thank you, Rob. I'm moving on to the items brought forward from the consent agenda for discussion and voting, starting with the strategic risk register 7.
Thanks, okay, so it's the standard risk report. The only change I want to highlight is the reduction in the risk scoring of SR of 006A, which are relating to our digital system resilience. This is known to be a site and massive accountability base, and some of what we've done around cyber risk that we felt we could reduce the risk score slightly. There's still 6 risks that are outside our appetite, which we are continue to focus on as an organisation and as a board. So other than that, there's nothing more to report.
Any questions?
I'm happy with the change of risk score for 6A. I think the thing that I noted from this report was the paragraphs towards the end around the dating system and the 4 years it's taken to get to a system that doesn't meet core requirements and is being recommended not to be used. How have we gotten to a place where we spent 4 years having that done and then deciding not to use it? Where's that piece of work being led from, and what money we spent to get to that stage?
Yeah, so there's a national programme board that's been leading the work linked to the Wales Data Test Programme. Health boards have engaged in that process, but it's been led nationally. I'm not aware of the costs associated with that damage, and we did commit a detailed briefing on the data test programme. The decision hasn't yet been made not to go to data test. Acting on that, so a recommendation will come forward for consideration about what that will mean for us and what our alternative could potentially be. But yeah, we'll pick that up.
Part of the reason why is I'm conscious that we've now had that nationally there's been a substantial number of national systems that had similar issues. And I'm conscious they've all been led from slightly different places, some from DHCW, some came out of the NHS executive, some from NHS SSP and various other places. I'm just conscious that this is another example of a development that has taken a substantial amount of time and isn't meeting our needs. And very clearly, national programmes need to be led differently and done differently so we don't end up in the situation again.
Noted.
Yeah, just to add that with that, the digital governance review being undertaken at the moment, being led by the Chief Exec of Cardiff and Vale alongside DHW and Mike Emery as Chief Digital Officers. We're waiting for the outputs of that governance review to address that very point.
Yeah, that's okay. I really shouldn't be commentating on this, but isn't it much like crises? You know, it's a be all and end all, and suddenly it isn't. And then here we have Datex again, and these things come forward and they're pushed. We spend a lot of money on them, and then suddenly they're failure. It's unreliable. How do we carry on with how do we carry on with something that's unreliable whilst we're waiting to process some other program? I don't know.
Yeah, so I think happy to have a more detailed report later on it. I'm conscious that this is another example of a national digital system that has not delivered what we expected.
Yeah, just to be made very clear.
Datex, we do have a Datex system currently running, and we can rely on the risk management. It's about the transition to a cloud-based new system.
Right. Okay. Thanks.
Just to be clear, we have transitioned to the new data system for incident management. I have different opinions on the effectiveness of that in terms of what we need, but we have transitioned and we are about to transition for safeguarding. So it's one module within a number of modules for Datix, because it's a system that has bolt-on modules for different areas of work, effectively.
I would say what Jenny said, really. I think there's some specific challenges with the new Datex module that need to be worked through.
Well, we have to be extremely careful because we can't have patient safety Anyway. So the computer systems. So we'll take that up again. Gallery. Anything else on the strategic risk register? No. 723, the Public Service Ombudsman of Wales letter. Jenny, please.
Thank you, Chair. So this is our annual letter from the PSOW. There is data within it, and there are a number of recommendations from the PSOW. As an outcome of the board discussion, we will write back to the PSOW and confirm the actions we've taken. So the PSOW received 175 complaints related to the health board, 23-24, which was in line with the Welsh average. That they do it per 1,000 residents, and they did intervene on 37% of cases, of which we are above the intervention rate of Wales of 31%. I should caveat to say that's made up of interventions around clinical care and treatment concerns and complaint delays. So it's not solely related to concern delays. We are doing some further work to look at that. Having said that, the work we've done to improve the quality of our responses, the timeliness of our responses, and our interaction with complainants, we've set some new communication standards for investigating officers, I think will prove dividends in terms of where we are next year. So much of the improvement work we already have in place will address the concern that the Ombudsman has on their intervention rate. I should say that there's a particular note within the report on the relationship that the Ombudsman has with us, in particular, Rhiannon, who is my head of complaints. There are a number of things that we're continuing to do. So we implemented all of the Groundhog Day 2 recommendations, which was the PSOW report. You'll know that we've already implemented our PAL service, and that goes from strength to strength. This week we've appointed, through some Welsh Government funding, a role to focus on end of life, to work with families who are very distressed at the end of life. We are putting our PSOW recommendations into AMAP so we can track that, and we are 75% compliant with timescales, which is a real improvement. And we've obviously had on the consent agenda the new Putting Things Right concerns policy, which works in line with the regulations, but focuses our approach on having that more interactive communication with families as they progress through a complaints process. We don't get it right every time, and we will continue to focus rigorously on learning from those cases where we don't get it right. And I'm happy to take any questions.
Thank you very much. Are there any questions, Jeremy, on this? It would be helpful, I think, if we advise the public ombudsman for the number of clinical incidents reported. It would be helpful to know in what specialties they are, or at least in what divisions they are.
Yeah, we
just so that we can see the
that data. We'll obviously drop the letter back in.
Thank you.
Oh, sorry. I was thinking that exactly. So is for our benefit, is there a special area, particular area is affected? Do you know now of?
No, I can't even. But it would be across the divisions. We do have divisions that have higher reporting rates, but generally they'll have higher activity. That's why you have to look at it per 1,000.
Number 7, the consent agenda, and on the basis that all those items have been requested to be brought forward for discussion by ourselves today, can I ask the board to confirm that it's content to adopt the remaining consent agenda in full with approval, noting the items outlined? Are you happy for that? Thank you. So for noting 721, board action log with updates. One of those in helps. Oh, okay. Are there any issues on the 7.2 part of the agenda? No. Okay. Any other business? No. 8.2, date of the next meeting will be the 27th of November. I look forward to seeing you all well before then. I'm going to move the motion to exclude members of the public and the press so that we might have an in-committee session. Thank you, which will follow immediately.
Thanks all.
Thank you.
I am online. Can I ask you to join the next link, please? Thank you.